Thing.
Yeah, Nitish, can you just give the count so that we can start?
Yes, yes. So I am starting the countdown. Three, two, one, start.
Sapna, you will introduce first.
No, sir. So you can just give a context and then
Good afternoon, everyone. I'm Dr. Deepak Talwar, and we are starting today Pulmoconnect, which is connecting 50 medical colleges and teaching institutions across India in this 8 module program, which is starting with its first module today. This module is on imaging in respiratory diseases, and as we understand very well, that pulmonary medicine is integrated to the imagings because it's one specialty which is heavily dependent on it. Chest X-ray is one of it, and it is the not only backbone but starting with our differential diagnosis to all management decisions related in respiratory diseases. Today, the imaging has gone beyond just looking at the diagnosis and management, but also guiding phenotyping and disease severity assessment and to make supportive decisions regarding the treatment of pulmonary diseases. And of course, monitoring disease progression and response to therapy is all a part of it. From chest radiology and high resolution imaging, which has come through not only the CT scans, but a very good MRI scans and many more advancements in this investigative field, the functional and quantitative measurements of the lungs can also be seen through a radiological imaging techniques. And hence we are translating pathology into clinical practice by using the advanced imaging techniques, which includes imaging by using radioactive photons as well as various MRIs and even a very good quality CT scans. This module will focus on how to use imaging practically, appropriately in day-to-day care settings and teaching postgraduates as to how a clinical decision making as to which radiological investigation should be the first one is the most important to learn through this module. So with that, let us begin this session on role of imaging in respiratory diseases. I am on the behalf of Dr. Richa Gupta because she will be joining in very soon to take this program forward. But very importantly, this program has been designed very excitedly, very exciting program, because you will all be participating in question answers. These questions will be pushed actually before we start the session, also at the end of it, and there are a lot of other things which needs to be learned. So the technical details as to how to each postgraduate, senior resident, or a doctor working in pulmonary medicine in these 50 institutes can participate into this can be explained by Sapna only, because she's the best person to do that. So I hand over to Sapna to take care of this.
Thank you so much, sir. And we are really glad to be supporting PACS in this very interesting and engaging transformative learning initiative that is Pulmoconnect. So this is so you've very well summarized the session for today. So just to make this session more engaging and more interactive, we are using a very innovative platform. And this particular QR code is only for the students, the PGs and senior residents who have joined us. So the session will be streamed live on the Zoom link. And I request all the PGs and SRs who have joined us to scan this QR code. Uh, I'll take a pause here for around 2 to 3 minutes. I'll request you all to please scan this QR code. Each doctor, each PG or SR who is attending this session, please scan this QR code. Alternatively, you can log into eventbuzz.live and use the code NSP92BA0. So the QR code is the easiest option.
So all of
Once
you, please take out your telephones and scan this QR code, and that will be utilized for you basically in answering the questions which are going to come. And then she is going to tell you again that why your answers will be taking you to many prizes. Much later, we will tell you about that. So it is very important. Please scan this on your telephones. Sapna, if somebody joins late, how are they going to get it?
So we'll share this QR code every time. I mean, before starting the quiz, and our team also has the QR code.
Okay, fine, good. Go
Yeah.
ahead.
So once you scan the QR code, you will be able to see this screen where you have to put in your email address. You can put in your email address, and you will get an OTP on your email address. You can put in that OTP, and then you will be taken to the main platform.
क्या वो नहीं सर एक बुड्ढे का प्रोग्राम करना है 16 तारीख को 16 जनवरी को
So, yeah, this once you successfully log in, this is the page that you would be seeing. And we would request you to please keep this page open on your mobile phone throughout the session, because there will be options for you for you to ask questions, to engage and interact with the faculties throughout the session. So there are much more interesting aspects to this, but please keep this page logged on your phone while throughout the entire 2 hours of the session.
Please write your questions. They will be coming to the moderator, and moderator will be actually using these questions to ask the speaker as soon as the talk is over. So you can keep writing your questions.
Yeah, so as Sir just mentioned, there is this option where you can type your questions. So throughout the session, whenever you have any questions in mind, you can just type it out here and you can submit the questions. And these questions will be visible to all the participants throughout the entire session. It will be visible to the participants. It's very important for you all to be very inquisitive and keep asking questions, because we are assigning points for each and every participation from your end. So there are points for asking questions, there are points for upvoting and downvoting. So when you ask questions, these questions will be visible to all the participants, and the participants have an option to upvote the question in case they feel that that question is very pressing and they also need the answer. They can upvote the question, or else they also have the option to downvote in case they think that other questions are of priority and that needs to move up. So based on the number of upvotes, the questions with maximum number of upvotes will be seen on the top, and the moderators will have the option to pick the most important or the most upvoted questions and answer them after their talk. So that is about upvote and downvote. Now we also have quizzes. So there will be a pre-session quiz. Now immediately after this briefing session, we'll have a pre-session quiz, and then we'll have a quiz at the end of the session. These two quizzes are to assess the outcomes of the learning. And the post-session quiz winners, top three winners of the post-session quizzes, will get exciting prizes. And Dr. Deepak Prajapat is our quiz master. So PAX has exciting prizes for the top three winners of each quiz. So,
So I think we are announcing this first prize winner will get Amazon e-vouchers of 5,000 rupees with registration to PAX Nova 9 and various other webinar series free. Second prize will be Amazon e-voucher for 3,000 rupees and registration for PAX free again. And third prize will be Amazon e-voucher for 2,000 rupees and again a registration for Nova 9 PAX free. So these are for each session, three prizes where you have not only Amazon e-vouchers but also registrations free for PAX.
So yeah, these are very exciting and interesting prizes from PAX, and the quiz winners will be decided during the post-session quiz. So the participants giving the maximum number of answers in the shortest period of time would be the top three winners. Now it's also very important to stay active and actively engage and participate throughout the session. Ask questions, upvote, downvote, participate in the quiz, because we are assigning points for each of these. So for every relevant question that you're asking, you will get 10 points. For every upvote or downvote, you will get 1 point. For every right answer in the post-session quiz, we'll get 10 points. And the top three winners of each session will get 100 points. And these points will be calculated, will be summed up, and they will be carried forward to the next sessions. And we'll have live leaderboards visible throughout the session. So this is a competition, because at the end, after all the 8 sessions, we again have grand prizes for the most active top three participants across the 8 sessions.
And these are going to be much bigger. First prize Amazon e-voucher of 15,000, and for packs everything free, registration, travel, stay, everything for Nova 9 packs. Second prize will be Amazon e-voucher for 10,000 rupees and registration and stay for Nova packs free. And of course for third prize Amazon e-voucher for 7,500 rupees plus registration and travel for Nova 9 packs free.
So these are again very exciting prizes. So I request you all to please stay active throughout the session and join us for all the 8 sessions, because these grand prizes are for the top 3 active participants across the 8 sessions that we are going to have over the next 8 months.
Don't forget,
So
10 points for each question you ask. You can accumulate a huge number of points by just asking your questions.
yes, sir. So I think with this, I'll hand over the session to sir for beginning this learning experience. But before that, if you all have not yet scanned the QR code, please scan the QR code, and we'll be running the pre-quiz session, the pre-session quiz live right now. We'll be making it live. Ravi from our technical team, can you please help us put the pre-session quiz live? So you'll have around 10 minutes to answer these questions. There are 16 questions that will come up. You can answer it within 10 minutes. Please scan the QR code and keep this the screen on your mobile phone.
I
So
hope all of you have scanned this code.
yeah, and yeah, when you scan, you get this option of take quiz. So once that is visible, you can click on that and you can start with the pre-session quiz, and you'll have around 10 minutes to answer this.
If you are not able to get this or there is any hassle going on, there will be a local representative available in your center who will be help you to do that. So please scan the code if you have not done so far. And we are going to start the pre-module quiz. And this is a set of 16 questions which are going to come. And in the meantime, I'll tell you that today's flow is we are going to cover across all imaging techniques which we use. And we are going to start. And we are going to start with the chest X-ray imaging and with a correlation of what is going on in the lung, particularly the disease as well as lobe as well as segment, which will be taken by none other than Dr. Rajesh Gothi. Everybody knows he's a legend figure as far as pulmonary medicine imaging is concerned. Followed by that, there will be a CT scan which will be discussed by Dr. Khushbu Pilania, again a name which all of us know very well, practicing and learning imaging from her on the CT scans, and Dr. Gothi as well. Moving on further will be Dr. Richa, who will be joining soon for basically talking about imaging of pleura and other structures by ultrasound. And then there will be ventilation perfusion scan, CT angiography, and some other test which Deepak Prajapat will be taking. And finally, the MRI, role of MRI in chest medicine, which will be taken by Dr. Kanishk Kumar. So we have all kind of imaging techniques which we use in our daily practice, and the idea to learn is when to order, what and why, and when it comes, how to interpret yourself, at least to the extent that you can go and discuss it with your radiologist and apply it into your clinical practice by making decisions about diagnosis, extent, severity, and the management of the pulmonary condition. With that, we can start the quiz now. Deepak, you take the quiz, please.
Yes, sir. So, Swapna, can we?
Sir, actually, this quiz will be just live on their mobile screens. They can take it, and the post session will be moderated by Dr.
Okay,
Prajapati.
great. So
Okay.
that saves time. That saves
Yeah.
time. Very
So
nice.
we'll give them 10 minutes. We'll keep it live for 10 minutes.
Okay. I think it's been live for how long? Because I've been talking quite a lot.
So I think it will be live for next 10 minutes.
Okay.
It's live
So
right now.
I think it's good that we hand over to Dr. Rajesh Gothi, who's I think one of the most leading the radiologist who works with pulmonologist, and he has guided all of us in our various spheres of life, including the difficult, complex cases, as well as I think it's been a long association, 25 years nearly. And I think amazing kind of, the diagnosis has been made with the help of him, giving his insights into various imagings. So today he's going to take over and start with the imaging, which is our basic actually. I think the backbone of pulmonary medicine is a chest X-ray. And you will all agree that by the time we finish our post graduation, we become a little bit of radiologists to read the chest X-rays. And now is not the time to stop at chest X-rays, but to move ahead than that. And none other than Dr. Joe Gothi is the person who can teach us that well, that gives us the confidence of doing it in our daily practice. So I will now hand it over to him. I think if the quiz has been done, can the backend team tell us that if the quiz has been done, because sir will take over now.
Ravi, is the quiz done or do we still have some time left? Sir, I think we'll give them
We have
5 more minutes.
4 minutes to do.
Yeah, 4-5 minutes more. Yeah.
Hi sir, I'm so sorry.
No
अभी अभी
problem,
बात
Richa.
है.
So the backend team, please help Dr. Richa to get the wallpaper, and she'll take over after this now. I just filled in for you, Richa, till the time you join. Thank you very much. So we are now, the quiz is going on right now. It's just
Okay sir.
finishing. And then Dr. Gothi will take over the imaging.
Sure
After
sir.
Dr. Gothi, I think 4 o'clock Khushbu will come, and once the
Okay sir.
Khushbu is over, then you'll take the ultrasound, and then
Okay sir.
Deepak will take the other investigations, and MRI will be the last by Kanishk. Okay?
Sure sir. Sure sir.
Right. Okay.
I'll see.
So in the meantime, we are preparing.
Yes sir.
I think I will. Sapna, we have sent today's case for discussion
Yeah, we have sent it
by
to the
the
HODs.
by the department heads. They can discuss with their postgraduates. That's the real case, and the most important thing is to discuss which investigation or which imaging investigation will help most under which circumstances, for which I think you would have shared it with all of them. Is that right?
Yes, sir. We have shared it with the HODs. Yeah.
Okay, fine.
It has been mailed to them. And in case the mail hasn't been delivered, our team also has the case. They can provide it.
Okay, so I think you can backend team can contact that if they have received that case, and if they have any, they can go and discuss it. If they want any clarification, they can directly put a message to me.
Yeah. Sure, sir.
Can we start now?
Ravi, how many minutes more to go?
I think it's just 1 minute, so we can start.
So do you get an idea how many people have already done this backend?
Yes. Give me a sec. Around 50 persons have submitted.
Okay, fine, good.
No.
We can go ahead. I think, Richa, you take over, please. We can
Sir, do
start
I
with
need to introduce sir?
everything has been done already.
Okay.
Dr. Gothi, if you please share your screen and start your lecture now.
Am I audible to you?
Yes, sir. Yes, sir.
Okay, let's start. So, good evening, all of you. I'm very thankful to Dr. Deepak Talwar and everyone in the organization who have given me this opportunity to speak in this August conference. And I do hope I make some of you, convert some of you into radiologists. So, the chest X-rays are, I would use a phrase over here, shades of gray is all I see whenever I'm looking at a chest X-ray. So it is from these shades of gray that you make a chest X-ray. Both normal structures as well as diseases have a breadth of gray shades, and which range from white to black. And from these shades, you have to make out what is the disease and what is normal. So let us look at the three shades of gray that we normally see in an X-ray chest. These are white, gray, and black. So in a normal X-ray chest, you will see white shades of gray cast by the cardiac shadow, fat, blood vessels, cartilages, and pleura. Gray will be lung parenchyma and bones in an X-ray chest, and black will be air wherever it is present. Same thing will happen in diseases. White, gray, and black. White is in fluid, consolidation, collapse, cartilaginous lesions, masses, cysts, and abscesses. Gray is fluid in the tissues, intralobar or interlobar fibrosis, and fat. And black is wherever air is entrapped, whether it's a pneumatocele, whether it's an emphysematous bulla, a bowel loop herniated into the lungs, a pneumothorax, or an emphysema. So you will see that basically we are dealing with these three shades of gray, and between these three shades of gray, we have to combine all of them and then come up with some sort of an opinion and then correlate with the clinical findings. Now, one of the things which a lot of people are confused about is that the X-rays are black. Normal X-rays are never black. They are gray in shade because they just don't contain air. They also have soft tissues, they have blood vessels, they have thickened fissures, and therefore, unlike air, say in the trachea or in the bulla, which is completely black, the air in the lung parenchyma is generally gray. So if you take the HU values also on a CT scan, you will find that they are gray and not black. Now, the next thing is you have to look at the anatomy and architecture of the distribution of different structures within the lung parenchyma. Is there any distortion? Is there any displacement of the vessels? Is there any deficiency in the distribution of vessels? And in which direction of these are these structures going? So whenever there is distortion, think of ILD, post-op changes, and chronic diseases. Whenever there is displacement, there can be a push because of SOLs and pull because of volume loss. And whenever there is a deficiency, it could be a congenital absence of a part of the lung. It could be a vascular cause like a pulmonary thromboembolism, or it could be a cyanotic congenital heart disease. Coming to the direction, all blood vessels should go towards the heart or away from the heart. But if they go in a different direction, not towards or away from the heart, but towards the, say, diaphragm or towards the apex of the lungs, then they are abnormally directed. So look at this for coming to the, just to show you a case of anatomical distortion. Here we have a chest X-ray in which we find that the left diaphragm is not well made out. There is a soft tissue opacity in the left chest. The bowel gas shadows are elevated, and the mediastinum appears to be shifted slightly towards the right. Also, we look at the right diaphragm. It is low in position as compared to the left, of course, and quite low, in fact. So when you look at the CT correlation, you find what has happened here is that the diaphragm has gone up. There is an eventration of the diaphragm or phrenic nerve paralysis, whatever is there in this case. The bubble gas shadows have moved up into the chest, and you see that there is a lesion over here involving the thymic gland, and there are necrotic areas within it. So we can make out, by the anatomic distribution that something is wrong in the left chest, which is why the diaphragm has gone up, and which is why there is compensatory overexpansion of the right lung. This was a case of tuberculosis affecting the thymic gland. So when we combine shades, all shades of gray with anatomy, and we add clinical data to it, then we get a most likely diagnosis. And from there, I'm not saying a definite diagnosis because you cannot make a definite diagnosis all the time from an X-ray. You will say most likely diagnosis. And then we know from there how to proceed further to manage these kind of cases. So there is a checklist. So the first thing in the checklist is to make sure that the patient data is correctly written on the X-ray. If it's a male, make sure that's a male's X-ray. If it's a female, female's X-ray, right, left, centering, everything you have to make out. Look at the technical quality of the X-rays. Are they good enough X-rays, or do these X-rays need to be repeated? Then I'll show you some examples of the cases that we have compiled in the last few days, and we will discuss those cases. So now look at these two X-rays. They are the same patient. The X-ray number is the same. If you look at this X-ray, this is an expiratory film. The lung fields are looking hazy, and you will probably say that there is pulmonary edema or something wrong with the lungs. The same X-ray taken after deep inspiration shows that the lungs are looking completely normal. Now here I want to say another thing. When we say that the chest X-ray is normal, we are saying that we cannot see anything in the X-ray. The lung may be having a pathology, the chest may be having a pathology, but the X-ray is not revealing it. So what I'll say here is that the X-ray does not show any obvious abnormality. It's a completely normal looking inspiratory film. This was a film which was technically not so good because the lung fields were looking hazy and were casting a doubt in the minds of the radiologist who was reporting it. That is myself. Now, another thing which happens very often is you see things like these, soft tissue shadows. And if it's a female, make sure that it's not a braid of hairs and it's not an image artifact. Have the X-ray repeated. Otherwise, you'll end up calling this lesion over here as some sort of a tuberculosis or some other lesion. So make sure that the X-ray is taken in such a way that there's nothing overlapping on these X-rays besides the normal bones. Anything which is overlapping on the X-rays can cast a shadow and mimic a disease. Here also, if you look at the shadow, which I have marked here with the arrowhead, it looks as if there is an opacity over here. But the opacity is not present because this whole thing is going all the way across the chest. So on the other hand, when the X-ray is repeated, the opacity is also disappeared. Effect of rotation. Very often, the technician is not able to produce a film which is absolutely well centered. And sometimes when it is rotated, you get a shadow like this, a prominent hyla. Make sure that this is a prominent normal hyla and not a mass in the hilar region. You can do that by looking at the blood vessels. The blood vessels are actually leading towards the hyla, and the hylar density is not increased. So it's a normal hyla which is overlapping on the left lung because of the rotation. It's not a pathological hyla. And compare it with the normal side. The normal hyla is absolutely fine. This is looking more lucent because it is overlapping on the lung. Had there been a pathology over here or nodule or something, it would have become dense. So the lucency point tells you that although it is rotated and looking prominent, it is a normal hyla. So next step, correlate all X-rays with the clinical data. Clinical data is the single most important thing which can tell you whether there is a disease or not, or no disease. And if there is a disease, is it correlating with the disease process that the clinician has described in the requisition form. It is also very important to compare X-rays with the previous studies. It's very, very important. It is like, if you get say a person, an X-ray which is 10-year-old or 5-year-old and showing completely normal, then you know that the disease has happened in the last 5 years' time. And this has become very, very important after the start of COVID. We always want to know what was the pre-COVID status of the patient and what is the current status. So a normal X-ray does not mean a normal chest. It only means that the X-ray is not revealing anything. It is not saying that the chest is normal. And I will show you a couple of examples of that also. So there are certain areas in the chest which are tricky areas where there is a high possibility of missing findings. So let's get into that. So one is the apices of the lungs, the periphery of the lungs, the central area of the lungs, and the lower zones of the lungs. So virtually you have to look at the four corners and the center. And by center I mean mediastinum. What I have noticed is that most pulmonologists concentrate on the lung parenchyma, and sometimes they look at the pleural spaces. For them, the heart and mediastinum does not exist. And if they look at the heart and mediastinum, they will look at the hyla. So there is where the role of the radiologist comes in, because he looks at everything. And we are nowadays very smart. We also look at the clinical data. The another thing which happens in females is that when they see these gray areas over here, they start a lot of physicians, general physicians, and internists, they start calling them as lung lesions. Now, if the breast shadows are sumptuous, you can get these gray shadows because of the presence of fat. This should not be mistaken for a disease. So disease, which is bilateral symmetrical, is very uncommon. Gray shadows in the lung parenchyma in the basis in a female are compatible with breast shadows. Don't miss the mediastinum. Don't miss the hyla. Don't miss the periphery of the lung. Don't forget that the lungs have apices and the inferior area, the abdominal area of the lung parenchyma. Always look for the presence of a gas shadow over here. It's very, very important. Then, the X-rays also change as time goes on. The X-rays of patient will change from childhood to adulthood and to old age. And therefore, you have to develop in your own minds what an X-ray of this person should be looking at a particular age. Do not think that the X-ray will remain the same at all ages. So therefore, you have to tune on to see several ages X-rays of different age groups to develop that mental picture of the X-rays that you will see in a particular age group. Another very important thing is the mediastinum, the hilar area. The hilar area is like that of a mustache, a drooping mustache. So they are well defined, sharp. They are like this, well defined, sharply outlined, tapering towards the periphery. Again, same thing, well defined, sharply outlined, tapering towards the periphery. They are not very dense. The density should be equal. There should be no lobulation, and they should end smoothly towards the lung periphery. They should not go upwards or downwards, outwards or inwards. Therefore, the hilar area becomes very, very important to ascertain. Also, look at the mediastinum. The pulmonary, if you look at the trachea and bronchus, there is hardly any space between the trachea and the pleura. If there is a space between the trachea and the pleura, or the bronchus and the pleura, that means something is there in that region, which could be causing this kind of a shadow. It could be a lymph node, or it could be a mass lesion. Look at the hidden areas. For example, in this case, when I did this X-ray, I was looking at the lung parenchyma was looking all right. It's an old X-ray, 2008, but very interesting because the lung parenchyma was looking all right. The only thing which I found was a little unusual was that the density here behind the right clavicle was lesser as compared to the left clavicle. So there was something happening behind the left clavicle which was not obvious from this X-ray. So the next step I did was I asked for an epicogram, not a CT scan. So when I did the epicogram, initially I magnified this image, and you can clearly appreciate that there is a difference in the densities between the clavicle on the right side and the clavicle on the left side. So on performing the epicogram, you can see that there is a cavitating lesion here in the left apex, which would have been completely missed had I passed this X-ray out as normal and not concentrated on the left apical region. So very important to look at hidden areas. Again, evaluate the mediastinum carefully. As I said, there should be hardly any gap between the trachea and the pleural stripe over here. If there is a gap between the trachea and the pleural stripe, which is more than, say, a thickness or double the thickness of the tracheal wall, it is abnormal. So there was a lymph node over here. Obviously, you think of lymph nodes and masses. So in this case, of course, it was a right paratracheal lymphadenopathy, which was causing this kind of a shadow. Now, you can sometimes have the ascending aorta, which can also protrude like this, but the ascending aorta is not a smooth outline. It does not produce a lobular outline. So if you see a lobular outline, invariably it is a lymph node, and sometimes it can be a mass. Now here example, same example over here, a lot of gap between the trachea and this pleural stripe over here. And this is also lobulated. A corresponding CT shows a lobular necrotic lymph nodal conglomeration. Again, white lung. You can see the smooth bulge over here. This is pleural effusion. Very often what happens is there is a small quantity of pleural effusion and or an opacity in the chest, and the clinician starts thinking of consolidation. In such cases where you find an opacity in the chest, you first of all, I think, ask for an ultrasound. It can easily clarify whether it is pleural effusion or consolidation. Another example over here, two sets of cases. This is a consolidation over here, and there's a consolidation here on the left side. The consolidation is telling you that there is something wrong with the lung. It's not giving you any histopathology or microbiology. So therefore, you have to be very, very careful in saying pneumonia, but we don't know what is the cause. It can be a primary pneumonia or a secondary pneumonia. So here in this case, it turned out to be Klebsiella pneumonia. And here in this patient, on taking the history, here there was a history of fever. And in this patient, there was a history of cough, hemoptysis, and weight loss in a smoker. This was a large bronchogenic carcinoma sitting over here. So if you are not given the history, it is very difficult to distinguish between these two lesions. I would have called this as a tumor and this probably as pneumonia. But because there was a history to back me up, this was a history of fever. So it was a consolidation infective process and this was a malignant process. So history is very, very important, and under no circumstance you can ignore it. Again, this female patient, the breast shadows are here, but there is a difference in the density between the two breast shadows. Now, had this patient been a lactating mother, I would have thought maybe it's because of lactation that she's got a difference in the densities between the two breast shadows. But this patient was not lactating. She was in her 60s. And obviously, there was a lesion over here. And this is a ground glass opacity, which you can see on X-ray chest. Ground glass opacities are not just seen in CT scans, but also in X-ray chests. So you can make it out that there is a lesion over here in the right lower lobe. Somebody had called it tubercular, but it's very, very unlikely that this is a tubercular lesion. And I wouldn't have put my money on that. I think it's a simple pneumonia, which should clear off in some time. Again, if you look at this film, we've got consolidation, we've got a cavity, and we've got a fluid level. So these three things point towards an abscess within a within an area of consolidation. So whenever you see these kind of things, also look at the inner wall, inner layer. It is smooth. So it's very unlikely that this is a malignant process. It's probably an infective process, cavitating pneumonia, rather than a malignancy. But naturally, you'll do a sputum examination. And in this case, it was a Pseudomonas infection, which had produced this cavitating lung lesion. Look beyond the lung shadows. The cardiac shadow in this patient is, and as pulmonologists, you have to look at the chest as a cardiopulmonary segment, not just as lungs. It's a cardiopulmonary thing. The lungs are affected by the heart, and likewise. So here we got cardiomegaly, and we got right pleural effusion. So when I get this kind of a case with a history of shortness of breath, I will do an ultrasound first to make sure that there is no pericardial effusion. If there is pericardial and pleural effusion, I would think of tuberculosis. I look for tuberculosis. And if there is no evidence of tuberculosis, then I'll ask the patient whether there is any joint problem or not. Can it be a connective tissue disorder which is doing this? So that is the way I'll go about it, and then try to look at the history and other clinical data. There are certain X-rays that are very, very dangerous as far as we radiologists are concerned, where no abnormality is expected and you land up with an abnormality and get into trouble. It happened just now. I had missed a case in which there was an abnormality in the tracheal middle end of the trachea of the clavicle. And the clinician pointed it out, and she sent me this paper here, and she had written, kindly reread the CT report to comment on the right clavicle malformation. I looked at the CT scan and I said, it's looking normal. Then I said, okay, let me look at it again. Why did the clinician say that there is something wrong with the clavicle? And when I looked at it, I found that there was synostosis of the middle end of the right clavicle with the right first rib. So instead of the clavicle joining the sternum, it was joining the first rib, and there was a fibrous union between the middle end of the clavicle and the rest of the clavicle. So whosoever had seen the scan in the clinical department was obviously smarter than me and made me cut a sorry figure. But I learned a lesson from this, so I'm quite happy about that. So there are certain areas where you can get into deep trouble and don't want to do it all the time. So like this patient, he came for a physical examination for a job. Now the mediastinum looks a little wide. It should not be more than 8 centimeters in width, but whether it was really wide because of the slight rotation towards the right side, whether this was sternum or whether it was a real lesion. So when I was looking at this X-ray, I found that there was an opacity over here in the left lower chest. So this looks like an extrapleural soft tissue opacity. So then I made up my mind. I thought maybe most likely there are lymph nodes over here and there is an extrapleural soft tissue opacity. The whole thing could be tubercular. So I've asked this patient to go for a CT scan before he gets this job. Now this patient came for a routine X-ray, was admitted in the ICU. You got a thing over here which the ECG leads are attached. I was looking at the X-rays. The right CP angle looked a little unusual. And as I was looking at the bones, I found that there was something wrong over here. I could not see this part of the bone. I zoomed the image and you can see over here that the bone is gone. So this is a metastatic deposit, which I saw in this film. And the patient came for a routine X-ray, was admitted in the ICU for some other purpose. And had I not looked at the periphery of the lung, of the chest carefully, I would have missed this deposit and later on cut a sorry figure. So getting to know chest X-rays is a long process. Every day you can have a success or a failure. And at every level, this can happen, whether you are a novice or whether you are a consultant, whether you are a retired consultant or whether you think you are a boss. I mean, you can make a mistake every time and you have to be very, very careful. Admit your mistakes and go on with it. Don't curse yourself, don't kill yourself over it, but fine. And I believe that a CT scan is any day the best teacher for learning X-rays and how to interpret those X-rays. We must keep learning from our mistakes and do our best in the hope of attaining perfection one day. But that day is most likely not going to come in our lifetimes. So with that, I thank you very much. And I think I'm well in time and I'll stop sharing my screen now.
Thank you so much, sir, for such a nice insight into how do we see chest X-rays and what are the problems which can happen and how we should be actually be careful about missing out those hidden areas. That is something really, really very useful. I would, can we look at if there are any questions where sir can answer if it is related to X-rays? The backend team, do we have? Okay, we have. All right. It seems we don't have any questions from the audience at the moment. So, sir, thank you so much for your insight and for such a lovely lecture. On behalf
Thank
of
you very much.
PAX, we and and Pulmoconnect, we thank you from the bottom of the heart for all your nice insights.
Thank you.
Thank you so much, sir. We have our next talk by Dr. Khushbu Pilania. Who will be talking about the HRCT. But at the same time, I would take this opportunity to ask all the people who have joined us, can you please scan the QR code which was given if you haven't done it yet, so that we can, the quiz is easy and you can ask the questions, you can put on the questions, and as it would have been explained earlier, if you are asking the questions, there are points for it. It shows how much engaging you are with our talks. Like, it is meant for you. So please make use of it completely. Please scan the QR codes in your phones and be interactive with us. Thank you. Over to you, Khushbu.
Thank you, ma'am. I'll just share my screen. Is my screen visible? Is my screen visible, Dr. Deepak? If you can give me a go ahead, I'll just.
Yes, ma'am. It's visible.
All right. So, hi, a very good afternoon, everyone. At the outset, I would like to thank Dr. Deepak Talwar sir and Dr. Richa ma'am for giving me this opportunity. And definitely talking after Gothi sir is a huge task in itself. But let's see. The idea of talking about CT after X-rays, as Gothi sir has already explained, that CT is one of the best teachers for X-rays. But nevertheless, X-rays always come first, and that is the first step towards this. So once we start looking at a CT scan, we need to know what are the various basics of imaging and how we go about interpreting it. So the first and foremost thing that I would like to address is what is HRCT? So every time we talk about lungs, we talk about HRCT. So HRCT is nothing but it's a high resolution CT scan where the acquisition is the same. It is just a reconstruction, especially in the current era. Earlier days, when we did not have helical scans, HRCT used to be an acquisition, whereas now it is just a reconstruction. So the difference is very clear from these two images. The image on the right is a normal CT scan, while that on the left is an HRCT. The second question is fine. This is HRCT, but why HRCT? So why HRCT? The simple answer is we are looking at lung parenchyma. So as long as we are talking just about mediastinum, about the bones, about the paravertebral soft tissues, routine CT reconstruction algorithm works fine. But whenever we are talking about lung parenchyma, we cannot see them unless we do these high resolution scanning. Because over time we've realized that lung parenchyma is a very intricate structure with very meticulous details, thin septate, thin alveoli, and we will not be able to image them in detail unless we do this high resolution imaging. So apart from doing the high resolution scan, the technique is also very, very, very important. So nothing in interpretation makes sense if the scan is not done well. So if you can put more time into getting your scans right, interpretation will be a byproduct. So amongst the techniques, it's very important that the scan should be acquired with adequate breath hold. So if the patient is continuously breathing within the scanner, you will just get artifacts, GGOs. There will be no interpretation of what you are looking at. Then the scan should be an end inspiration. So the patient should have taken a full long breath, should hold it for a while, and the scan should be taken. We should always complement it with an expiratory scan to look for any airways or functional abnormality. Always ask for volume images, because gone are the days of conventional CT scan wherein single slice, four slice CT was done. Almost every CT scan in current day and era have helical imaging. So always ask for those volume images. Try to get your series where you can reconstruct those images to get your answers. Think of doing prone scans wherever the question is ILD. Get good reconstructions, as I always mention, and you should know about the various post-processing tools like maximum intensity projections, minimum intensity projections. So this is the crux of getting a good CT scan. The moment you get a good HRCT, then we will talk about how the interpretation is. Now, going ahead, once you've got your scan right, it is important to understand what you are looking at is normal or abnormal. Obviously, that's why I'm sitting here. So, how to define something as normal or abnormal? One of the commonest things that we've been doing since our earliest days is, especially in cases where we have two parts, and as pulmonologist, you know, you have a right lung and you have a left lung. So you always look at the images and compare. And if you see any asymmetry, you raise a concern that yes, there could be an issue. But we need to understand that there is a lot beyond it also. So obviously asymmetry means an issue. The second step will be what is the issue. The first step is also that sometimes there is no asymmetry. In those cases, to define, is it still abnormal or is it normal? So, well, let's look at this CT scan. So when I look at this CT scan, absolute symmetry, I'm not seeing any focal lesion. I might be tempted to call it as a normal CT scan. But when I know this is normal, so this is an image you should keep imprinted in your mind. This is how a normal lung looks like. So this lung parenchymal attenuation, this is the normal attenuation of a lung parenchyma. It is similar or close to that in the of the air. So slightly darker than the air, but very close. In this case, it is much grayer than the air in the trachea, and we know it is definitely abnormal. So you should not be misled by symmetry. You should be very confident about what is normal or abnormal. Then we discussed about getting the scans right and about the fact that we need good breath hold and end inspiratory images. Why? Because look at this image. So once you look at this image, are we confident enough? So the patient has come with respiratory symptoms. This is the set of images that we get. Are we confident enough to say that this is normal, or are we confident enough to say that there are GGO? We are confident about none. But at the same time, same patient, same section, when it is acquired in good breath hold, you know there is no abnormality, at least in this section. You'll be very confident in labeling the patient as normal and starting the treatment basis this CT scan. Similarly, what is the role of end inspiration? So when you get a scan in mid inspiration, you get this kind of a GGO. So you are getting some haziness, which is increasing as we are going down. Whereas same patient, same level, when this scan is done in mid-inspiration, which we can see by this rounded trachea, you see a very homogeneous, similar attenuation of the lung parenchyma top to down. Again, a place where you might be tempted to call it a GGO turns into absolute normal. So that is why an end inspiration is an absolute must. Having said that, how to identify whether this is an end inspiratory image or an end expiratory image? So let's look at this example. So there are two images. Which amongst these is an expiratory image? So if people will put answers into the chat box, or I'm not sure, or maybe I just go ahead saying that when we are looking at these images, we have A and B. You can answer for yourself, and we know that it is B. So the B is an expiratory image. Why? Because a round trachea means an end inspiratory image, whereas a trachea which is flattened on the back means it's an expiratory image. So again, you see a round trachea and you see a flattened trachea, inspiratory and expiratory image. So this is how you differentiate inspiratory from expiratory. The question now comes is, fine, we can differentiate, but what is the real need of doing an additional set of CT scan on a patient? Why should we really do expiratory? We can do a good inspiratory, say that the lung parenchyma is normal or there are GGO, whatever it is, we can characterize the abnormality. The answer is, look at this inspiratory scan. So it's a good end inspiratory scan. Lung parenchyma looks pretty much normal. There is no abnormality. But the moment we do an expiratory scan, we realize that we have these area of air trapping, this large area of air trapping in the left upper lobe. So the moment you see this, you know that there is an insult, there is some past insult, there is a small airways constrictive bronchiolitis, and possibly that was the cause of the patient's symptoms. So this would not have been picked up had we not done expiratory images. So that is the role of an expiratory image. Again, another example, inspiratory looked pretty much normal, but on expiratory, we could see complete air trapping in the left lower lobe. We could see these prominent bronchi also if we now try to look back. And we know that again, it's a constrictive bronchiolitis. This is again of great role in interstitial lung disease imaging, where the presence of air trapping raises a reasonable suspicion for the presence of hypersensitivity pneumonitis. So you see that between the two images, the mosaicism accentuates. We are more confident of the presence of mosaicism. Mosaicism in a case of interstitial lung disease very strongly points towards a chronic hypersensitivity pneumonitis. So that's why we say that in almost all situations, except in patients who are follow-up cases of interstitial lung disease, an expiratory set is must, or in cases which are known malignancies, known tuberculosis. But wherever the diagnosis is not known, we are suspecting airways or interstitial lung disease for the first time, expiratory set is a must. When doing these images, avoid the voice commands, try to train the patient beforehand. Then the question is of prone images. So why should we do prone scan? So we often come across such a CT scan with some opacities towards the bases. Now, either we say these are dependent opacities or we say this is an interstitial lung disease. So dependent opacities is a normal lung, and interstitial lung disease is something which is really serious. So between these two, we have a huge gap. And giving these two large differentials becomes giving no diagnosis at all. So that is why a prone scan is important. The moment you do a prone scan, you see that these opacities disappeared, and you are very confident in saying that it is only only a dependent opacities. Another similar companion case where you see similar dependent reticulations on prone scan, they persist, and you know it's a very early interstitial lung disease. So that is why it's important to do the prone scans. The call whether or not a prone scan needs to be done can be taken on a case basis. Similarly, often when you have reticulations towards the anterior segment, a prone scan can be avoided because this itself means that the fibrosis is there. It's a non-dependent area. So just to summarize, the HRCT technique that is a mandate must for a patient will be a good inspiratory volume scan, which HRCT reconstructions, which is 1 mm at 0.5 mm interval, followed by an expiratory scan. Then we need prone scan in all fibrosing interstitial lung disease for the first instance if there is no one to monitor. If there is a radiologist or the pulmonologist himself herself to monitor this, then you can avoid it basis the need. We should always ask for volume images. Forget about the films, get your images on a cloud-based software. So after all this is done, so once we've got our scans right, only then we start interpreting. So what I talk from now on makes sense only if you got your scans right. None of these interpretation will be valid on an inadequately done CT scan. So when we talk about imaging interpretation, with respect to lung parenchyma, we have a few terminologies. So we saw that lung parenchyma has a baseline inherent attenuation or a shade. It is slightly black in shade. It's a black shade lung. So within this black shaded lung parenchyma, if something is blacker, that becomes low attenuation lesion. So something which is blacker, the differentials include emphysema, cystic areas, honeycombing. Within the black lung, you can see a lot of lines. When you see a lot of lines, we start calling it reticulations. On that black sheet, if you see a lot of nodules, then these are nodular opacities. Or if there are whiter areas on the background of black, this becomes higher attenuation areas. So that's how the terminologies are. And then we start defining the imaging appearance of each of these. So among the blacker areas in the black lung, these are the four important entities. Let's see how each one of them looks like. So when we talk about honeycombing, so this is a normal lung attenuation. You see blacker areas. So these are cystic air spaces which are present in clusters with a similar diameter. They can be a single layer or multiple layer. They are subpleural, they share wall with each other and are associated with architectural distortion. So when you see such blacker areas in a lung parenchyma, we call them honeycomb cyst. The other differentials are emphysema. So when you see blacker areas which do not have walls, which are not coalescing with each other always, so they are scattered, intervening lung parenchyma is normal. When you see such holes without walls in the lung parenchyma, it means it is centrilobular emphysema. Paraseptal emphysema is another blacker area within the black lung. These are cystic spaces which share wall, but there is no architectural distortion. They are single layered. And then these are known as paraseptal emphysematous changes. Bronchiectasis are again blacker areas. So these are dilated bronchi. They are more often tubular, but they also appear cystic. The way to differentiate them from other cystic spaces is trying to scroll the images on your computer or laptop, and when you scroll them, you see the contiguity. So honeycomb cysts, etc., even centrilobular emphysema, paraseptal emphysema, cystic lung disease, they do not communicate with each other. Bronchiectasis communicates. So when you see such communicating tubular channels which are moving towards the hyla, you know you are dealing with bronchiectasis. Cystic lung diseases are again blacker areas within the lung parenchyma. These blacker areas have well-defined walls, but they do not share wall with each other. There is no architectural distortion. The intervening lung parenchyma is normal. Then we start calling them cystic lung diseases. Then we come to reticular pattern. These are lines within the lung. So this is a normal lung. These are a lot of irregular lines. So when these lines are irregular, you think of fibrosing ILD, of which UIP, IPF, and chronic HP are the commonest. Often these lines are smooth, as you see in this case. They are not as irregular. So when you see these smooth lines, always look for effusions. When you have smooth line, there are very limited differentials, of which pulmonary edema is the commonest cause. Often these lines are nodular. So there are these nodular blotches. So when you see these nodular lines, think of sarcoidosis or lymphangitic carcinomatosis. So these are reticulations. So when you see lines, try to describe them in one of the three patterns, which will help you narrow down the differentials. Then you have nodules. So you have dots in the lung parenchyma. When you have dots in the lung parenchyma, we divide them basis the distribution of the dots and the character of the dots. So for example, when you see these look like discrete nodules and not ill-defined. So we can easily see them with the eyes without straining them, and we will need a sharp pencil to draw them. So when you see these peribronchovascular fissural distribution, discrete nodules, you know you are looking at a diagnosis of sarcoidosis or meningitic carcinomatosis. Often you see these other random distribution. So when you see this, the differentials become pneumoconiosis and biliary tuberculosis. In this case, you have to actually strain your eyes to look at the nodules. So these are centrilobular. Why? Because you see the periphery of the lung is paired. They are not subpleural. These are centrilobular nodules and ill-defined. So ill-defined centrilobular nodules means you are looking at hypersensitivity, acute hypersensitivity pneumonitis. So this is how you define the nodular pattern and describe them. Amongst the nodular pattern, you also have tree in bud nodular patterns. So in this, you have cluster of nodules with the typical tree in bud and branching pattern of distribution. This is very typical of bronchiolitis, could be infective or inflammatory. Often the nodules are rather large, discrete single nodules. So these are known as solitary pulmonary nodule. Anything which is more than 8 millimeter, less than 3 centimeter. Often some of these are very typical nodules where you have a diagnosis straight at hand. Often they are indeterminate, in which case you need to biopsy them. So these are the various, they can be smaller nodules or subsolid nodules, and we have very apt Fleischner criteria on how to deal with these nodules, especially when they are in incidentally detected solitary pulmonary nodules. I'm not going into those details, that we'll discuss later. Other wider attenuation areas within the lung parenchyma is ground glass. When the lung parenchymal attenuation, so this is the normal lung parenchymal attenuation, when you see areas which are wider but still not as wide to obscure these vessels. So these are known as ground glass attenuation. Ground glass attenuation is something which can be seen with myriad of pathologies. So no single ground glass is pathognomonic for a single pathology. It means that there is lung parenchymal infiltration, which can be from anything as simple as just dependent opacities to anything like malignancy. Then another term that we use with respect to lungs is mosaic attenuation. Mosaicism means patches, anything which is in patches. So this is a normal lung. Then in this, you are seeing mosaicism. So black, white area. So whenever you see two different shades in the same lung parenchyma, we start calling it mosaicism. So mosaicism can be due to differential air retention or air trapping. It can be due to differential blood supply to the lung parenchyma, as happens in cases with pulmonary thromboembolism, or it can be due to differential infiltration, as happens in cases of hypersensitivity pneumonitis. So in cases when it happens due to differential perfusion, that is due to differential vascular supply, the appearance remains same between inspiratory and expiratory, as against cases of mosaicism which happen due to airways disease, in which the attenuation changes between inspiration and expiration. The mosaicism becomes more prominent in expiration in cases where it is due to airways disease. And also it becomes more prominent in cases of lung infiltration and airways combined together, like in cases of hypersensitivity pneumonitis. Amongst the other simpler higher attenuation areas, you have the consolidation. So when GGO is as dark that the background lung vessels are obscured, you start calling it consolidation. When you talk of consolidation, always remember to talk about air bronchogram. So when you see this branching air bronchogram, you know it's a consolidation with air bronchogram and patent proximal bronchi. Often you do not see the air bronchogram, but you see fluid bronchogram, also known as mucus bronchogram. That means the lung parenchyma is not well aerated. There is definitely some proximal obstruction to the airways, and we should be actively looking for that proximal obstruction. Often these bronchi also contain high attenuation mucus, which is a highly sensitive sign to pick up allergic bronchopulmonary aspergillosis. So this is a bright attenuation and this is the normal attenuation. Please note it's a non-contrast scan. So if you see on a non-contrast such whiter areas, this is called the high attenuation mucus sign. So that was about the various imaging patterns on HRCT. Just a couple of words about how beyond CT scan there is a role of MR also with interstitial lung diseases, and we've lately started realizing it even more often. So cardiac MR is one place where, especially with respect to pulmonologists and especially with respect to interstitial lung disease like sarcoidosis, etc., there is a huge role of changing the management of the patient, helping the patient get better. So we pick up early infiltration of the heart with the cardiac MR, delayed gadolinium enhancement, which tells us, especially in cases of sarcoid, where often we are tempted to not to treat patients, we know that these patients will require an aggressive management. So cardiac MR is one place where there is a huge role in especially chest sarcoidosis and even in cases of CTD where a cardiac involvement is suspected. Then another important budging up role of MRI is with respect to the myositis protocols, especially in cases of interstitial lung diseases. We've started picking up the myositis also retrospectively. Patients often present with it with an interstitial lung disease, and a myositis which was rather early and not a clinical manifest was picked up on the MRI so that an aggressive management can be instilled before the ILD changes into a rapidly progressive ILD, which is often associated with myositis related ILDs. So before winding up, the take-home message is a good quality study is an absolute must. You should understand where you should switch to other modalities. Correct interpretation is not tough. It's a simple byproduct of adequate acquisition, especially in the current AI era. It's just an acquisition which is very, very, very important. You can manage to get your answers if you've got the acquisition right. Thank you.
Thank you so much, Khushbu. As always, it was so much enlightening. Anytime I hear this thing, I always get one or the other message. So I'm sure the audience and the postgraduates especially would have benefited with the way you have very nicely explained and how to pick and how to see the things. Khushbu, can I take an advantage of asking you some questions? Goti sir has left actually because he was to go to the hospital. Some of the questions which are just X-ray related and some of them are of course CT related. Okay, so one thing is,
Yeah.
can we differentiate mediastinal lymph node from mediastinal mass on a chest X-ray?
No, ma'am.
It is
Okay.
difficult, certainly. I'm just, okay. Impact of rotation in lung shadow itself in a chest X-ray, if it is
So, ma'am,
rotated.
it often, I mean, if there is a lung parenchymal shadow per se, often we can pick it up. So, currently, the role of chest X-ray is predominantly to say there is an abnormality, we need a CT scan. So, that
Right.
can be done even if there is a rotation. Characterization becomes difficult with respect to mediastinal lesions. Rotation creates a bigger issue. But like often, if there are sick patients you cannot manage without rotation, it's fine. We can say that there is some lung parenchymal lesion or not.
Okay. And I think this one is also on a chest X-ray, how to differentiate lung abscess with loculated hydropneumothorax.
So there are quite many signs which tell us to differentiate how a lesion is intraparenchymal versus pleural based. So amongst them, the obtuse angle sign, the fact that it is going. So hydropneumo is anyways rather easy because it goes along the CP angle and you see those loculation, the obtuse angle, etc. So it becomes easier when you're trying to differentiate between the two.
And also we can do a lateral X-ray, which might help in
Yes, absolutely.
differentiating with. So other question is from CT scan. On CT, how do you differentiate hydropneumothorax, fluid-filled cavity, and infected bulla?
So, to differentiate hydropneumothorax, I mean, you see pleura, the fluid is all along the pleura. It's a D-shaped. So, if you look at the axial CT scan, you see a D-shaped collection, which is closely abutting the chest wall, so the ribs. So you have the ribs, then you see a D-shaped collection, you see a air fluid level, that's hydropneumothorax. How to differentiate it from an infected bulla? So infected bulla, mostly it must have ruptured or something. Or if it's, I mean, infected bulla is something I don't know how will an
Maybe
infect.
it is probably asking it's a fluid-filled bulla.
So ma'am, fluid-filled bulla will no longer be a bulla.
So it's basically what they are asking is, Khushbu, that there is a bulla in which there is a air fluid level and it's a laterally placed, and you have a hydropneumothorax which looks the same. So
Okay.
it's the convexity of the borders, concavity
Yeah.
of the borders, anything can help.
So, sir, the
But
parenchyma, so when we are talking about a bulla, it's a parenchymal lesion. So, if it's a parenchymal lesion, the margins with the pleura are always acute. So, that's the same way we differentiate an abscess as was asked. So, abscess and bulla both will have an acute margin. Bulla will have a thinner wall versus a thicker wall for an abscess and more lung parenchymal changes with abscess. Though I've not seen an infected bulla myself ever. So, that's.
and most of the times it may be really, really very, very challenging to diagnose it. And that is why I think people are asking it, because ICDs are put into bulla, which are in, like,
Yeah.
later on developing a bronchopleural fistula, but not expanding lung because it was in the lung rather than in the pleural cavity. So many times it is a difficulty. And even in a CT scan also, you will say sometimes it is really difficult to say that it is laterally placed bulla with the air fluid level or it's a loculated hydropneumothorax.
Yes, sir.
That's the, I
It
think, kind
may.
of a situation which is very difficult sometimes. So I'm sorry, Richa, I had to jump in because this question is very near and dear to me because we find lot of times patients are transferred that it is not healing. It is not healing because it is in the lung actually. It was
Right.
never in the pleural cavity basically.
So, sir, I think most of the time when this is being done, it is probably just on a basis of the chest X-ray they are doing it. Because once you have a CT, it helps you almost 90% times you are very confident about whether it is a loculated bulla or it is a kind of a thing. I mean, I feel
Everybody
so.
is not that privileged to have the radiologist like
Ha,
Khushbu
I
and
can.
the ones which are in CMC Vellore, because even the radiologist can get confused on that. So I think that's a perfect thing. But I think if the patient is not in respiratory distress, then take your own time basically to
Right.
decide what it is. And it is not that if somebody has just come with a hydropneumothorax with stable vitals, no hypoxia, no need to put in a hurry, put a tube at that point of time. You can wait and let it be discussed more with the radiologist. And then maybe a decision might be taken. This acute angle thing and an obtuse angle thing is the very helpful thing which I had brought on a CT scan. But still, it can be confusing in some cases. We have seen that it happens, especially when it is loculated on the top. It becomes very difficult at that point of time. And
It's a
obviously,
larger bulla. The larger bullas create an
large
issue.
bullas can be very, very confusing. But if there is any bullous area or a bulla in the other lung, that should be actually a
Flu.
very big red flag to see that maybe it is also same and it's not ruptured one. Previous CT scans or previous X-rays help a lot to decide that what it was before. I think that's comparison is also very important. Are there any questions? They want to flash the QR code because people are joined a lot. I think I'm told that there are
Later.
200 plus postgraduates already on board, and they want to have this QR code for asking questions. Up voting, down voting, and everything is getting numbers to them. They are very happy to get more and more scorecards being filled. I think imaging and the both chest X-ray and CT scans have almost amalgamated now. It's like
Yeah.
one leads to other very soon, and I will I think there are lots of medical colleges people. I would like to share with them actually. Our diagnosis of ILD as a first diagnosis has improved from 4 years to 2 years according to the recent surveys, which must be because of the CT scans availability, early CT scan availability, and of course it is cheap.
So I think, sir, there's one more question we'll take up before we go on to the next talk. That's for you, Kushbu. What about the vessels within the mosaic attenuation in differentiating vascular and small airway disease?
So, especially when we are trying to differentiate vascular versus small airways disease, in both the vessels within the darker areas are less in caliber compared to the whiter areas, because even in airways, the areas of air trapping tend to get lesser perfused. So, that for both of them, the difference may not be as much. But definitely, when we are talking about a vascular cause for mosaicism, in this, there is no change in the extent of air trapping between, or the extent of mosaicism between the inspiratory and expiratory images. When we talk of airways disease, on the inspiratory images, they look rather normal. On the expiratory image, you start seeing a differential caliber of the vessels and difference and the blacker and whiter areas. In infiltrative lung diseases, both the caliber of the vessels in the black and the white areas remain more or less similar.
So we have actually almost taken all the questions. Can we locate segments in chest X-ray? They are asking, but probably yes, you can do. As far as you know, you have to do a lateral chest X-ray. Segments, nahi, but lobe at least you can identify. Is that right, Kushbu?
Yes, ma'am, absolutely.
Lobes you can
I will
differentiate
add
by
one more
doing a
thing,
chest
Khushbu,
X-ray.
that is the lateral film a dying art?
Yes, sir, dead.
Almost dead.
Yes, sir. Sir, I mean, the learning curves of people who are doing chest X-rays also now. So the technicians have lost the art. So even they are not doing. So the effort which is required to, so the protocol, we keep harping about a protocol for CT scan. So it's important to do the chest X-rays also adequately. So unless without rotation, with good inspiration, with good exposures, unless these X-rays are done with that effort, the x-rays also don't give answers. And sir, at least now people have started putting effort on CT. Now to go back and tell them that for 200 x-rays a day you put that much effort, nobody is doing it, sir. I
But
mean,
we have a lot of medical colleges today with us which may not be having a CT scan facility or CT scan possibility of doing it in every patient. So
sir, it's
still the
becoming,
standard bronchopulmonary segments are taught on the PA and the lateral view, and I think that should go on for the postgraduates
sir,
to
I
have a
think it's
basics
becoming
of
worse.
learning.
So, but it's becoming worse with AI coming up. All x-rays have been pushed to AI reporting. And so there is no answerability to what's happening on x-rays.
So
So, I
CT
mean,
scans have got more accountability and answerability
yes,
at
sir.
the
I
moment.
personally think so.
At the
Yes,
moment.
at the moment, agrees. Yeah.
So we can go ahead. I think Richard, take next one.
Sure. Thank you so much,
You are,
Kushbu.
I think it's Richa's turn now. So
Yes, sir.
the person who has done so much work on pleura and right from the ultrasound to the pleural interventions, I think we are going to listen to her, the role of ultrasound. I think you are the best one to talk about ultrasound, Richa.
Thank you so much, sir. Let me just share my. It's a screen visible, sir? Swapna, screen is visible?
Yes, ma'am.
Okay. So, good afternoon, everyone, and thank you, for sir for providing this opportunity to speak on something on a topic which is very, very close to my heart, is on lung
Slide visible, but
ultrasound.
you're on the slide mode.
Yeah, I'll move now. Okay. Is it okay now?
Yes, ma'am. Perfect. Perfect.
Okay. So, next 20-25 minutes probably, I'll be just talking about what, as a postgraduate or an early career physician, you should be knowing on an ultrasound, because ultrasound has radically changed the way we manage our patient both in and out patient departments. Ultrasound, is it something which is going to replace the chest X-ray, or is it something which is going to replace the CT scan? Certainly not. But it has proven its own value because it is non-radiation, it is bedside availability, and images are reproducible as well. Ultrasound examination, I feel, is just the extension of the physical examination, and we are able to characterize the disease process properly. Now, whatever the ultrasound finding is there on a chest, we have to apply it, because even negative findings are important. We have to apply it with a full clinical knowledge of the patient. Other imaging modalities are important, but ultrasound is repeatable, non-invasive, and real-time, and that is why at some places it has an upper hand. So the objective would be, I'll just take you to the little basics of the ultrasounds. Then how does the normal lung ultrasound looks like, and what are the abnormal ultrasound pathologies? Now there is too much. Actually, you can keep on speaking, you can talk on, keep on doing, but since we have a limited time, we will try to understand the very common, and we look at the various signs. How do we diagnose on an ultrasound? The very common pleural and the pulmonary pathologies. First thing is the probes. You have high frequency probe and the low frequency probes, and these probes are something which are kind of the mother. It has to be there, then only you can do. Now, the thing is, if you are having, if there are people who ask that we have an ultrasound machine, but we have only probe, we have only one probe. In that scenario, I would advise you to have one high frequency and one low frequency, and we will see which are those one. So now the high frequency probe this is a straight linear frequency probe, which has 5 to 15 megahertz. It is high frequency, but it is used for analyzing superficial structures like chest wall, pleura. Okay. And these are the two low frequency probe. One is curvilinear probe and the other one is phase array, or it is also called as the cardiac probe, which is a low frequency probe. It has a very good penetration. It can see the depth into the lung, but because of that, there is poor resolution. So it is used basically for seeing the depth of the lung and for, say, parenchyma, if you have to evaluate. It's not good for visualizing the small superficial structures like pleura, if you want to characterize specifically for the pleural line or chest wall or vessels over the chest wall or anything related to that. Now, if you have to have, ideally all three probes should be there, but if you want to go on only two probe, the admin is saying that you can have only two probes, then I would suggest to have a phase array or the cardiac probe and a high frequency probe. Now, with this very basic information that which probe we need where, we'll ask you in between as well. Let's go on to what is the normal lung look like. Now, normal lung picture is nothing. It is an amalgamation of lots of artifacts which have been defined, and with those pictures in line, we are going to make what is this pathology. So it is just the artifacts. There is no picture, particular picture of a normal lung, and it is very important to understand these artifacts. The most important artifacts are the A line or reverberation artifacts and the B lines. There are a multiple of a series of artifacts, but in this class, we are not going to discuss anything about that. All we need to know is what is A lines and what is B line. That will solve almost 80% of your, problem or helps in diagnosing. The A lines are horizontal, hyperechoic. When I say hyperechoic in ultrasound, it means it is more towards whitish. Hypoechoic, and I'll just take a second to explain this also. We consider, when we talk, we have three terms we will use: anechoic, hypoechoic, and hyperechoic. And this in pleura or lung, when we are taking this, we are comparing with the corresponding liver on the right side or spleen on the left side. When I say isoechoic, means whatever the picture or the shadow we are seeing, it is same echogenicity as the liver. When I say anechoic means black. which is like fluid, is seen on an ultrasound. When we say hyperechoic, means it is going towards the whiter side. It is more whiter than whatever the echogenicity of the liver is. It is more white. And hypoechoic is little darker. So something between echogenic and anechoic, means black and white के बीच में it is hyperechoic. Don't get confused. We will show the pictures and then you will understand. Now, they arises when the ultrasound rebounds several times before returning to the transducer. And the property of A line is that they start from the pleural line, below the pleural line, and they start diminishing in the intensity as the distance increases from the pleura. So this is what we are talking about, the reverberation. So you will have the pleural line and then you will have these horizontal lines, which are called as the A line. I'll show you the video as well. So here is the pleural line and these horizontal artifacts are called as the A line. Now, what is the utility of diagnosing this A line? Presence of A line just means presence of air. Now, this could be physiologic, like in a normal lung, air is present, or this could be pathological. If you have got a pneumothorax, then you can have those multiple lines. Whether it is pathological or it is physiological, that you have to correlate with the clinical history of the patient. Let's go to the other artifact, which is called as B line or the comet tail artifacts. These are multiple ray-like vertical lines. Now, the property of these are they starts from the pleural line. Always extends from the pleural line and go to the lower edge of the screen, and they do not fade. B lines never emanate from the above the pleural line. And if B line are more than 3 in a field, it is considered as pathological. So if you are seeing 2 to 3 B lines normally posteriorly in the posterior aspect of the chest, it can be taken as normal. But if you see more than 3 in a field, or if you are seeing 1 or 2 B lines anterior chest, then this should be pathological. It should not be considered as physiological. This is how the B lines look. They originate from the pleural line and they go until the end of the ultrasound screen and they do not fade. You can see this is the pleural line over here. I'll just pointer, I will put it out. So this is the pleural line and you can see these vertical comet shaped artifacts are originating from the thing. They are not fading down and they're going up to the end. We just remember these A lines and B lines. As I told you earlier, that there is no particular shadow or particular design, I would say, of a lung. This is how a normal lung would look like. This is all just air artifacts. Pleural line is very, very important for us to identify. Pleural line, we will see how it looks like. So these are few things. Why I'm showing you a normal lung is, this is how a normal lung, this thing will look like, because unless you know the normal, you won't be able to identify the abnormal one. Right? This is just the normal. And when we are doing, it is important for us to identify how does the lung, how does the liver looks like, where is the diaphragm, and how does the spleen looks like. So when you do a lung ultrasound, you should be looking at, because when we are planning ultrasound guided procedure, then it is always, always important for us to identify how much is the depth from the diaphragm, or how much is the depth from the liver, how far I am, or how much is the depth from the spleen. It is very, very important, because sometimes, you know, when you are a novice ultrasonographist, sorry,
इसको ना थोड़ा बहुत सेटिंग यहाँ रख दो, कई बार का इमरजेंसी काम आ गया।
can we mute?
अरे वो कम
So-
का
Okay. Sometimes the spleen can be confused with a loculated small pneumothorax on the left side. And that is why it is very, very important for you to understand how the liver, how the spleen, and how the diaphragm looks like when you are doing a chest ultrasound. So this is all about the normal. Also, there are two modes. One is B mode and one is M mode on an ultrasound machine. B mode is the brightness mode, which is the normal mode we use for scanning our patients. And M mode is nothing but a time motion display of an ultrasound line at one point of time. So because M mode is useful in certain scenarios, that is why I would like to put up how does the normal lung in an M mode look like. The normal lung in an M mode is called as a seashore sign. So you have these parallel white lines, which corresponds to the water, and then you have this speckled artifacts, which looks like a shore. So this is what the normal lung in an M mode looks like. We need to identify pleura is the most important point which we need to identify when we are doing an ultrasound. Lots of our diagnosis is based on that. It's a single highly echogenic horizontal line below the chest wall. And lung sliding sign is something which is present normally. It is nothing but the movement of the lung relative to the chest wall, or we could say sliding of the visceral pleura with respiration. Let us look at that, because this is something important we should be looking at. Now, before I see the lung sliding, I would like to show you the pleural line. So I said the most echogenic line below the chest wall. So this is all the chest wall, the muscles are there, and the most echogenic line you are seeing, this is the pleura. This is in high frequency probe, and on my right is the I'm so sorry. This is in the low frequency probe, which you can see. You can see the depth, you can see the lung, and correspondingly on the right side is the high frequency probe, where you can see these are all the intercostal muscles. And this is how the most echogenic line is the pleura. Sometimes in high frequency probe, you can even see two lines which are coming. If I don't know if you're able to make it out, the visceral and the parietal pleura can be identified. Normally, they are not identified because because there is very minimal effusion between the two. You are not able to identify. This is what we were talking about, the lung sliding. Lung sliding is the movement of the pleura. You can see this is the pleural line, the most echogenic line. If I just pause this one, I'm not able to pause. Okay. If you can see, this is the chest wall, which is a static, and then this is the pleural line, right? This is the pleura, which is moving, which is shimmery, or some people even say it as an ant march. How does the ant walks, or a shimmery line kind of a thing. So this is how this is called as the normal lung sliding. If this is there, that means this is normal lung. Now we come to the pathology. So this was some little basic about the normal lung, the normal pleura, and about the probes we were talking. Now look at what are the pleuroparenchymal pathologies with ultrasound we can find. Pleural diseases, it is an excellent modality. Pneumothorax, pleural effusion, hydropneumothorax, pleural thickening, anything you can diagnose. Parenchymal disease, it is helpful in diagnosing alveolar consolidation, alveolar interstitial syndrome. If the lung mass is peripheral, we can also look at the function and the shape and size of the diaphragm, a bit of heart. As a pulmonary physician, I should be knowing a little bit about the heart as well, because the patient is sick. I should be able to distinguish between whether this problem, say breathlessness, is it because of the heart problem, or is it because of the lung problem? Pulmonary embolism as well. And of course, it is the must equipment when we are doing pleural related or lung related guided procedures here, say aspirations, biopsies, or follow-ups. Because the time is less, we won't be able to cover everything, but we'll try to take some pleural and common parenchymal diseases in this next. Okay. So we'll be talking about pneumo, pleural effusion, consolidation, and interstitial syndrome. When we diagnose pneumothorax, there are few things which we have to understand. Lung sliding, if it is absent, this may be suggestive of pneumothorax. Mark my word when I'm saying suggestive of, because lung sliding may be absent if there is pleurodesis already done for the patient. or there is pleural thickening, then also, or there is adhesions, then also lung sliding may be absent. So if lung sliding is absent, it may be suggestive of pneumothorax in correct clinical scenario. But if lung point is present, which I will show you in next few slides, it is almost pathognomonic of having a pneumothorax. Presence of A lines may be suggestive of pneumothorax, but as I told you earlier, it could be physiological, present in normal lung also. If instead of saying absence of B lines, I would say if B lines are present, this rules out pneumothorax. And in M mode, stratosphere or barcode sign, whereas normally it is called as the seashore sign. Let's just look at quickly. This is a normal lung sliding which we are seeing. Now look at this video. Here, if you could see, this is the chest wall and the most echogenic line is the pleura over here, and this pleura is hardly moving. This is absent lung sliding. Let me put up both the things together. And then you can make it out. Here the pleura is hardly moving, whereas here we can see the pleural line is nicely moving. So this is the difference between an absent pleural line, absent lung sliding and a lung sliding. And when we say absent lung sliding, we say they could be suggestive of pneumothorax, not 100% diagnostic of. Normal lung in AM mode is seashore sign, but if pneumothorax is present, then this is called as the barcode sign or the stratosphere sign. Let me put them together for you. So on my left is the normal lung. You could see the seashore sign, the parallel lines, and then this speckled artifacts, which is resembling like seashore. And when there is a pneumothorax, then you can see that these parallel lines are continuing below the pleural line as well, right? And this now this movement is gone, lung is collapsed. So this movement you will not see, and hence this is what we will see in our pneumothorax patient. Right? We come to the lung point. Lung point is nothing but it is a point where the visceral pleura starts separating from the parietal pleura. So if we have to look at somewhere here, so here at the point here, this would be the point where you may get a lung point. Now, a question of common sense. If there is a complete collapse of the lung or there is a massive pneumothorax or a tension pneumothorax where the lung is completely collapsed and come to the hilum, will you be able to see the lung point? No, because we don't have any, what do we say, the lung is completely collapsed and there is no place where the visceral and the parietal pleura are attached to each other or seen together. And if this sign is present, you can diagnose almost with 99% certainty that this is a pneumothorax. So this is how a pneumothorax would look like. You will have an, lung point would look like. You will have a point where you have absent lung sliding as well as the normal lung sliding. If you're able to identify this point, this is called as lung point. And this is, as I said, very much diagnostic of pneumothorax, right? Let's move on to other thing.
उसमें पावर बैंक मैंने डाल दिया था अंकल ने टेबल पे पावर बैंक तो नहीं पड़ा मेरा चार्जर वाला
Lung sliding may be absent in pleural symphysis, apnea, complete atelectasis, or ARDS.
इसे चार्जर
And
बैंक
bullous or obstructive lung disease may sometimes appear as a pneumothorax in an ultrasound. So we should interpret very cautiously. And that is why I'm saying ultrasound should always be interpreted in lieu of the patient's presenting history as well. Coming to the pleural effusion, sensitivity and specificity of 93 and 96% respectively, and certainly for pleural effusion, diagnosing for even detection to identify the etiology, loculation, septations, or quantification, ultrasound is certainly much better modality than a chest X-ray. And in identifying the septations within the locule, so internal septations, it even surpassed the CT thorax. Let's see. How do we diagnose pleural effusion? You have to identify the anatomic boundaries, chest wall anteriorly, diaphragm or subdiaphragmatic organs inferiorly, and you have a collapsed lung. And in between, you have something anechoic or black color thingy there, which is an echoic space. Sometimes dynamic changes are present, which is flapping lung, plankton. I will show you this on the videos. So all three signs, of which any one of the dynamic is present for the diagnosis of pleural effusion by an ultrasound. Now let's look at this. This is a pleural effusion. So as I said, anteriorly is the chest wall, right? And then we have these are two videos. So if we will see this one alone, you can see the diaphragm, this is the collapsed lung, and the black fluid, anechoic fluid in between is the pleural effusion. We can do the color sign. When we do a color sign, it implies, not always 100% true, that the fluid is usually free, but it is not 100% true. Now, can you see this? This is what I was talking about, the flapping lung or a jellyfish sign or a hockey stick sign also is a collapsed lung which can seen undulating up and down. There is an effusion here. This is called as the swelling sign, where you can see echogenic debris or echogenic shadows which are seen swelling within the pleural effusion with the respiration. Now this can be present in patients who have got hemothorax, or in patients with empyema, or in patients who have highly cellular malignant pleural effusion. There also you can sign. In one of the studies, actually, they found that, of course, not only the swelling sign, but there were other signs also, say pleural thickening or diaphragmatic thickening of more than 1 centimeter, presence of diaphragmatic nodules, and swelling sign. These three, if we combine, then it gives you the sensitivity of about 75% to diagnose that this could be a malignant pleural effusion. Coming to the sinusoidal sign, again, this sinusoidal sign is in M mode. So in a pleural effusion is black, it is looking like that. But if you put M mode, then you will see that the pleural effusion, this sinusoidal sign is present. Now, specificity is about 97% for the diagnosis of pleural effusion when we see the sinusoidal sign. Now, can anybody say, I know we are not interacting directly, but if sinusoidal sign is negative and you have got something like blackish area or hypoechoic area, you are thinking this could be pleural effusion. But if sinusoidal sign is negative, then most likely it is a very organized collection or it is pleural thickening. That is one of those, differentials you can think of. Multiloculated effusion, you can see a chest x-ray here, which shows you, okay, yes, there is a pneumothorax. A CT shows you, yes, there is a loculated effusion. But when you do an ultrasound, within this locule, how many internal septations are there? Ultrasound is the best modality to diagnose that. See, look at this multiloculated. This is how the multiloculated effusion would look like. So if you have something like this, probably you know why you are failing. If you haven't have an ultrasound and urodiagnostic aspiration for a patient based on a chest x-ray, your tap may be dry tap. So it is very, very essential that we should use ultrasound. Now, ultrasound quantification of pleural effusion, there are various ways of doing it, and radiologists have the various, they have the formulas where they can feed in. For us, it is very important to know that how much roughly will be the effusion so that I can plan my further investigation or management. So if it is just present in the costophrenic angle, it is considered as minimal, which is about less than 100 ml. If you put a probe into the place and it is only one probe, if we go up, there is no effusion, go down, there is no effusion. This is considered as a small effusion, about 100 to 500 ml. If it is 2 probe effusion, it is moderate, 500 to 1500. And if it is 3 or more, it is more than a 1.5 liter and it is considered as large or massive. Now, there are lots of formulas. It is available online, but this is a rough guide towards to know. Pleural thickening, how does it looks like? Pleural thickening will appear as a hypoechoic area. Usually it is focal, arising from the visceral or parietal pleura. It may be caused by scarring, fibrosis, empyema, pleurisio tumor. It may be misinterpreted as a small pleural effusion. So how do we do it? We do a either you do a color Doppler in the, so if it is a pleural thickening, you will not see the color sign positive, or you can do the sinusoidal sign as well. So this is how pleural thickening would look like, right? Something like this. If there is calcification present, then it shows that it is an old pleural thickening. This we have already discussed. Very quickly, because we are running out of time, lung pathology, how the alveolar consolidation and interstitial syndrome. Let me just put it up. Alveolar consolidation is what happened is we saw how the normal lung look like on an ultrasound. If the echogenicity of that lung has been changed as to the liver and spleen, 1 second. 1 second. Sorry. So if the echogenicity has increased and it is looking more like a liver or a spleen, then it is called as sonographic hepatization, and most likely there is a consolidation or a collapse. Irregular serrated margins, even the pleural line, if it is the peripheral consolidation, then the pleural line will also appear as serrated. Shred sign is called as the deep interface between the consolidated and the aerated lung looks irregular. I will show you. Now, when you have something like that, the differentials would be pneumonia or atelectasis or compression by the pleural effusion. So it is there. Here is where the ultrasound fails. If you have a consolidated echogenicity, you have even if you have echogenic, even if you have bronchogram present there, becomes difficult to say whether it is because of the pneumonia or it is because of the collapsed lung. Only if there is a dynamic air bronchogram, it is suggestive of pneumonia. If it is static air bronchogram, it could be pneumonia or it could be collapse. So this is how, consolidated lung would look like. You can see the echogenic shadows here and see the echogenicity of the normal lung has increased. So I just wanted to show you the normal. How does it look like? And then we see. This is how the air bronchogram or the consolidated lung would look like. This is the normal lung and this is the consolidated lung. You can see this is the shred sign, the irregular, between normal lung and the consolidated lung, you can see the irregularity. Alveolar interstitial syndrome, basically, it can be chronic, it could be acute. Chronic is seen in pulmonary fibrosis. Acute can be seen in ARDS or cardiogenic pulmonary edema or interstitial pneumonia. What do we see is the B line. That is how we diagnose. Now, very quickly, if you're able to diagnose B line and they are homogeneous, diffusely present, and the pleural line is smooth, most likely it is because of the cardiogenic pulmonary edema. But if the B line distribution is non-homogeneous, the pleural surface is irregular, and sometimes you may find subpleural areas of lung consolidation, then most likely it is non-cardiogenic lung injury. Let us see. So this, if you would say, this is, you can see the B lines, you can see, you can see the B lines are not homogeneous, they are irregularly placed, and the pleural line is irregular. Most likely this is because of the non-cardiogenic pulmonary edema, could be interstitial fibrosis, could be ARDS or interstitial pneumonia. Whereas if you see this picture, you have B lines, there are so many, they are homogeneously placed and the pleural line appears to be regular. This is very much diagnostic of cardiogenic pulmonary edema. Diaphragmatic function also, you can see, look at this, I'm quickly seeing. So this is the lung which is coming, and the white line, you can see the pleural line, and this is the diaphragm which is moving. For the other same patient, you can see how this diaphragm is moving, right? You can compare. So this diaphragm is not moving properly. So that is how you can compare. You can see the shape of the diaphragm. You can see the function of the diaphragm, and you can even do you can identify by doing a sniff test whether it is palsy or it is eventration. So this is how it would look like. Look at the movement, how nicely it is moving on the left side, but how less it is moving on the right side. So I think more applications are there, and as it has the ultrasound application as well as the use of ultrasound has significantly increased over last 2 decades, and there is no dearth of us using the ultrasound. In fact, it seems to be using it more often rather than using even a stethoscope. So with this, I will end, and thank you so much.
Thank you, Richa. We have got a lot of questions coming up. I think now people have geared up very well to ask questions, right? There are a lot of them there, and of course, uh, which is the best formula for quantification of pleural fluid on an ultrasound, I suppose?
Okay, so as I said earlier, also there are so many formulas are there, and as a physician, as a pulmonologist, I'm not even worried about it how much it is. For me, it is eyeballing to find out, even if it is a small effusion and patient is symptomatic, he will or she will require an aspiration to be done. So for us, I don't remember by name the different formulas, but I think I can put it up while. Deepak is giving his talk. I will put up some of the formulas which we have used in our studies in the chat box. So you can use that one, but I don't feel the clinical importance of identifying the amount of fluid for us as a physician, because for us, it is the symptoms of the patient which guide us to do the procedure.
So, Karthikeya, your answer will be put there, but definitely, even after the program is over, a lot of questions which are still left for the radiologist, we will be answering them, and you can get them directly from that group which we will be posting those, because I am finding very important and difficult questions which have been raised by people. One is again coming to you, Richa, how to distinguish when loculated hydropneumothorax vis-a-vis filled cavity on an ultrasound thorax. So CT scan they learned that may not be 100%, but there are subtle things which tells us X-ray chest is definitely a much inferior. CT is still better, but still it is not 100%. So like, can ultrasound be even more, indicating the differentiation between the two?
No, sir. So ultrasound fails in this completely. Completely, it fails ultrasound. In fact, if you have to differentiate a loculated hydropneumothorax or a cavity filled with fluid, X-ray may be a better modality than an ultrasound. The reason being, whenever air comes in, ultrasound just fails. So that is the reason
So,
we won't
Sabyasachi,
be
I
able
think
to identify.
yeah, Sabyasachi, your answer has been given that ultrasound is not better in any case, and by and large, at the moment, CT scan is the
CT
best,
scan.
and I think it will be little tough, especially if you don't see those concavities versus convexities, but because of the loculated effusions, but still the surrounding lung, what is happening to the rest of the lung, the previous films, as I said earlier, will all happen. There is another question that. Any signs for cystic lung diseases on ultrasound?
No, sir. I mean, cystic lung disease, if we are talking about the very, very small cyst, as I said, air-filled cavities, ultrasound fails completely. You can have, if you have this hydrated cyst, you may see it on. Water lily sign can be nicely seen on that, but otherwise, no, not particular as far as I know.
So hydrated cyst is the only one. Karthik, I think, is asking a lot of questions. I think he will get some award at the end of it. Ultrasonic elastography guided thoracic ultrasound pleural biopsy. So I think what he means is, will elastography in the ultrasound help to decide from where to take the biopsy better than a routine ultrasound?
So that's a very good question. And actually speaking, this is, I don't know who has asked. So thank you for asking these questions. But elastography in pleura is still evolving. And sonographic elastography has been used for other solid organ malignancies, say thyroid, breast, and it has done wonders over there. They are able to identify, depending on how hard the tissue is. The more the hardness is, the more the lesion is towards the malignancy. But unfortunately, the problem what we are facing, actually I'm doing on a research basis ultrasound guided ultrasound elastography and the pleural thickening. The major problem which is coming is, our we have lots of patients where the pleural thickening is secondary to TB disease or the pleural disease. So there also it fails actually. So at the moment, there are papers, but I'm not using elastography to diagnose. We are just in the research mode to identify. But because we have lots of pleural thickening secondary to TB, which is long standing, there is where we are finding it difficult to differentiate. And at the moment, I would say even just a routine ultrasound guided pleural biopsy is good enough. It is almost as equivalent to CT guided pleural biopsy for diagnosing malignancy or TB.
Okay, so Karthika, it's basically a work in progress. You might find it. We started doing for liver, and we found that fatty liver can be easily picked up on elastography better than what are these fibro scans and other things. So things are improving, and maybe it's ultimately, how much you use and whatever the new things come up, they will definitely help us. Should a LP needle be used as a routine basis for bedside ultrasound guided pleural fluid aspiration? So somebody has asked that, can you use an LP needle?
So
That should routinely be used.
we use actually at our center, what we are using is, there are rocket aspiration needles are coming, which has it bans as soon as it gets if it hits the lung. So we are using that, or we are using insights, the vein flown. So we put in and then we remove the needle part of it. So the LP needle, it's very thin and it is little longer. I haven't used as LP needle, but I do use only insights or the dedicated aspiration needles which comes from Rocket for the aspiration.
That's much better to prevent the accidental rupture of the lung. And
Yes.
LP needle just goes so smoothly in that actually you wouldn't know where it has gone. So I think it's not a good idea to use it, better to use. And I think what you said is the catheters, they are very good actually. The moment you have hit, the fluid is coming, you take the needle back so that let the
Yes.
fluid come out of it. That's very
Yes.
nice. So somebody has asked spine sign, what is its significance? Is it on ultrasound? Preeta, you put this question back again. Is this sign on ultrasound or a CT scan or a chest X-ray? Even I don't know. Before asking my,
So, sir, the spine sign on ultrasound is basically, if it is present, it's an indicator of pleural effusion. It's a fluid around the lung.
so it's like a spine which is seen, which is a fluid, right?
Yeah.
That's all I could imagine. Thank you very much, Richa. We can
Thank you,
move
sir.
on to the next one quickly. We have got a little delayed. I'm extremely sorry, but this is the first module. There is a lot of calibration and recalibration to be done. We would be doing it in the next episode. So PET scan and ventilation perfusion scans. And I request Deepak to just try to give clear-cut messages and try to finish it fast.
Thank you, sir, and very good evening, everyone. So, uh, I will talk about the PET CT because after so much discussion on the chest X-ray, the CT scan, and the lung ultrasound, now the time for the nuclear imaging studies, which are the modern studies, and they will help us in differentiating that which area we need to hit with the biopsy, because nowadays we have so much of modalities available for the tissue diagnosis. So the PET CT is very much helpful in uh, deciding that which site to be targeted. And then there are a lot of other advantages of using the PET CT.
Deepak,
Where,
your slides are not moving. We are still at the slide one.
okay.
Yeah.
So the PET CT is the fastest growing imaging technique worldwide, and it was first started in 1970. So its a fusion was put into the clinical practice in 1998. In this, the images, the uptake and the distribution of radio labeled glucose, which we are using in the body. And the PET alone is a functional imaging technique, while the addition of CT to it makes a PET CT both a functional as well as structural imaging technique. So the basic principle behind the PET CT is the widespread distribution of 18-fluoro-2-deoxyD glucose, the FTG, which is a glucose analog and is taken up in almost every cell in the body. And within the cells, the FDG is phosphorylated and is trapped, allowing it to be effectively measured by the PET. So FDG has a half-life of around 110 minutes. And the second principle is the radioactive decay of the positron rich these fluoride particles. And in PET-CT, we get the SU value, which is a standardized uptake value to quantify the FDG uptake at various sites, including lymph nodes, the lung nodules, and apart from that, the extrapulmonary sites. So what are the uses in the clinical pulmonary medicine? So it basically helps us in identifying the mediastinal lesions as well as the lung pathology. So in mediastinal lesion, the PET-CT can provide additional diagnostic information apart from the CECT. And the main role of is for the staging and the follow-up of malignant mediastinal tumors. Apart from that, nowadays there are a lot of papers published about the PET-CT in the diagnosis and the follow-up in patients of sarcoidosis where extrathoracic involvement is there. And also now there are a lot of studies going on for the treatment of tuberculosis where the prolonged treatment for tuberculosis is guided with the help of PET-CT. Then the malignant lesion, they showed increased uptake on the PET-CT as compared to the benign lesion. However, the overlap may still occur. As I depicted in the image, the upper image is giving the diagnosis of tuberculosis and the lower one image is for the malignant disease. So in both the conditions, the uptake is there. So the uptake, it basically tells us about how much is the lesion is active, metabolically active. And apart from the mediastinal lesion, the solitary pulmonary nodules, the PET is more accurate and specific than CT alone for characterizing the solitary pulmonary nodules, and it is useful in nodule of more than 8 mm. And in patient with low clinical probability of malignancy, a negative PET-CT has high negative predictive value. Low to intermediate risk lesion, which are metabolically inactive, it can be followed up radiologically in the routine clinical setup. The positive PET-CT in a clinical low probability states require a biopsy for the confirmation, as some benign disorders also show the uptake, as I discussed previously. In the patient with high clinical probability of malignancy, the direct biopsy is also useful. So all the lesions with the SU value of more than 2.5 is highly suspicious of malignancy and need a biopsy confirmation. But there are a lot of false negative reports with the PET-CT when we talk about. In cases where there is a lot of ground glass opacity in well-differentiated adenocarcinoma, the PET-CT becomes negative. The carcinoid tumors, the bronchoalveolar carcinoma, the solitary pulmonary nodule of less than 8 mm, and the mediastinal node of less than 1 centimeter, they can show a false negative result even with the PET scans. So for the carcinoid tumors, we have DOTA TET PET-CT, which is a specialized CT scan, PET-CT, to diagnose the carcinoid tumors. Just like that, we have a false positive cases also with the increased glucose metabolism, like in the various benign inflammation, pneumonias, pyogenic abscesses, aspergillosis, and more importantly, the granulomatous diseases like GPA, sarcoidosis, amyloidosis, IgG4 diseases, and tuberculosis, etc. And also, following any surgical procedure, if we do the PET-CT, it showed false positive uptake. Then it will help us in the staging of non-small cell lung cancer. The PET-CT emerging as a standard pre-operative assessment tool also. It is more sensitive than CT for staging and for differentiating the malignancies from benign lung lesions such as post-obstructive atelectasis. Also more sensitive and accurate in identifying the metastasis, and it may provide additional information in almost 40% of the cases. As the image you have seen in the picture, it showed that there is a metabolically active uptake along with the pleural effusion, and this patient comes out to be a squamous cell carcinoma, and because there is a pleural effusion, so it staged as stage 4. Then their role of PET-CT is also there in the assessment of response to the therapy. It helps us in detecting an early response to therapy. There is a criteria called PERSIST criteria for malignancies. The PET-CT performed 6 to 8 weeks after chemotherapy and 8 to 12 weeks after the radiotherapy. and there is a complete disappearance of metabolic uptake. If it is there, we call the complete metabolic response. If the reduction of more than 30% in SUV, we call partial metabolic response. And if the reduction in SUV is less than 30%, we call it as stable disease. And there is appearance of new FDG-avid lesions or increase in SUV of more than 30%, then we called it as a progressive disease, and we change the management accordingly. In lot of benign conditions, as I discussed, the sarcoidosis and the tuberculosis is one which we are talking about. It also helps us in deciding the treatment modality and monitoring of these diseases. Then in the follow-up of treatment of the lung cancer, the PET-CT is useful in following the patients treated with surgery and the radiotherapy. It differentiates post-treatment fibrosis and scarring from a recurrent disease process. And it also helps us in differentiating whether the patient we are treating, we have to go for the curative intent versus the palliative intent. If the patient is having a single metastasis in the bones, then of course the palliative intent is the key. In such cases, the change in radiation doses and the volume will help with the help of PET-CT scan. After the PET-CT scan, there is one entity which we call the ventilation perfusion scan. So in the ventilation perfusion scan, what is the basic principle which I want to talk you? That if there is a normal ventilation and the normal perfusion, no obstruction in both the process, we call it as normal. But if there is a defect in the ventilation, as in the image B is there, and the perfusion, the circulation is normal, then in such conditions there is a decrease in the ventilation perfusion ratio. And if there is a obstruction in the circulating pathway but the ventilatory pathway is normal, then in such conditions there is an increase in the ventilation perfusion ratio. So with this basic principle, we'll go ahead. So there are basically three types of defects which we can be found in the ventilation perfusion study. There are matched defects. So what are the matched defects? So in the first image, the ventilation and the perfusion defects, they are concordant with each other. This occur when the perfusion defects corresponds to the ventilatory abnormality. Suppose if patient is having a fibrotic lesion, and in the X-ray image or the ventilatory image, the lesion is there, and we found the same lesion in the perfusion area also, it is called the matched defect. The mismatched defect is where the defect in the perfusion with either normal or near normal ventilation. So what it means, the perfusion is abnormal but the ventilation is normal, then we called it as a mismatched defect, which is seen in pulmonary embolism, veno-occlusive diseases, tumor obstructing by an artery, or after the radiation therapy. Then the third entity is reverse mismatch. What is reverse mismatched is, so there is a defect in the ventilation with either normal or less severe corresponding perfusion defect. So as in the diagram we see the ventilation is affected but the perfusion is normal. So this condition is called reverse mismatched. So depending upon these pathophysiology, there are basically four pathophysiology states which we have to describe. One is the vascular occlusive state, where the ventilation is preserved in presence of perfusion defect, we call VQ mismatch, which I discussed. Consolidative stage, where the alveolar collapse and the atelectasis is there. There are leakage of fluid into the air space secondary to capillary leakage, and it showed the matched ventilatory perfusion defects seen in infections, inflammatory disorders, pulmonary infarction, and the atelectasis. The third one is the obstructive state, where the airway obstruction occurs from either narrowing or the closure of small airways or loss of structural support, excessive bronchial secretion, bronchial spasm, mucosal edema, and the foreign bodies. As a result, there is decrease in alveolar PO2, which leads to the constriction in precapillary arterioles, and there is a redistribution of blood to the better ventilated alveoli, which leads to matched ventilation perfusion defect. It is seen in asthma, COPD, and the bronchiectasis. The fourth one is the restrictive state, where hyperventilation may occur secondary to increased ventilatory drive, and it might lead to increased ventilation relative to the perfusion. It also leads to ventilatory perfusion mismatch. So now talking about some technique, how it done. So all the images taken by the gamma camera. So there are single photon emission CT ventilation scan. It performed using either radio labeled gas. So the ventilatory part, which we did with the radio labeled gas or radio labeled aerosol particles. And the material which we are using for this is the xenon 133 and the 99M technetium DTPA aerosol particles. These are the two commonest particles which we are using for the radio labeled gas or the radio labeled aerosols. Then there are certain latest material which are Techni gas and the Techni gas, which have a very low retention power. So these are nowadays very much popular in the research purposes. Then the second part is the perfusion scan. So always we do the ventilation study first, and after that we did the perfusion scan. So perfusion scan we done with the intravenous injection of radio labeled pharmaceutical distributed according to regional blood flow. So the particle which we are using for the perfusion scan are the 99M technetium macro aggregated albumin and the 99M technetium human serum albumin. So there are basically 8 views which we are obtained in the ventilation perfusion study: the anterior, the posterior view, left anterior and the left posterior view, left and right posterior and anterior oblique view, and the right and left lateral view. So these are the 8 images we are getting in the perfusion study. Now comes to the indication where we can perform the ventilation perfusion scan. So patient in whom CTPA is contraindicated, like in the pregnancy, the renal insufficiency, chronic kidney disease, stage 4 or more, and severe contrast allergy. So now the 28 up to 20 after 28 weeks of pregnancy, the CTPA is allowed with the abdominal shield. But the patients who in which the pregnancy of less than 20 weeks is there, the ventilation perfusion study is recommended. Then the diagnosis of pulmonary embolism, of course, the pre-operative evaluation before lung surgery in lung carcinoma to estimate the loss of lung function. Also the patient with the lung transplant pre and post-operative monitoring. Then for the measurement of cardiac shunts in various situations, and the evaluation of new onset pulmonary hypertension to detect CTPH in these group of patients. So the criteria to categorize the likelihood of pulmonary embolism with the help of ventilation perfusion scan, there are a lot of criteria were given, like original PIOPED, modified PIOPED 2 criteria, perfusion only modified PIOPED criteria, and the perfusion only PSAPED criteria. But we will concentrate on 2 criteria which are more popular and we are using nowadays, is the modified PIOPED 2 criteria and the perfusion only PSAPED criteria. So what is modified PIOPED 2 criteria? So in this criteria, they divided it into 4 parts: the high probability, very low probability, non-diagnostic, and the normal study. So in high probability, if there are 2 or more large mismatched segmental or segmental equivalent defects are present, and there are one segmental equivalent, means a defect of more than 75% of a segment, and the half segmental equivalent means a defect of 25 to 75% is present. We called it as high probability. The very low probability, when 1 to 3 small segmental defects are there, along with there are non-segmental perfusion defects smaller than X-ray chest lesion, 2 or more matched defects with normal chest X-ray, single match defect in the mid or upper zone, solitary large pleural effusion, or a stripe sign, that is the presence of peripheral perfusion in a defect. The non-diagnostic, when all other findings are present apart from these findings, and normal when there are diffuse homogeneous radio tracer activity on both perfusion and ventilation scans are present. Then the next criteria is the PSAPRED criteria, which is the easiest one. So it is a simple and eliminate the non-diagnostic readings. So after the COVID, the researchers, they do the studies only with the perfusion scan, not with the ventilatory scan. So the PSAPRED criteria, they basically perform only the perfusion part, and along with that they do the chest X-ray and they compare. So the pulmonary embolism present when there are 1 or more wedge-shaped perfusion defects are there, and pulmonary absent when there is no perfusion defects, non-wedge shaped perfusion defects, or the shape defects caused by mediastinum, diaphragm, or an enlarged heart is present. So this is the simplest criteria which they are using. So now talking about the specificity and sensitivity. So when we use the PIOPET 2 criteria in those patients where the pre-assessment with using the well score, if it is in the intermediate or the high category, and the PIOPET 2 criteria uh, showed the high probability, the specificity and the sensitivity of this criteria is 93%. Specificity is 93% and sensitivity is 85%. With the PISA-PRED criteria, the specificity is 97% and sensitivity is around 80%. And when we compare it with the CTPA, the specificity of CTPA is 98% and the sensitivity is at the tune of around 86%. So the PISA-PED criteria and the PIOPET 2 criteria, if we apply these criteria and we compare the results with the CTPA, it is almost equivalent to the CTPA. So how we read the pulmonary embolism? So this is the diagram which, this is the ventilatory perfusion scan, which showed in the ventilation scan, we get the anterior breath hold, anterior equilibrium, 3-minute wash, and the 5-minute washout test. So these are the 4 stages in which we do the ventilation scan, and the lower part showed the posterior breath hold, equilibrium, 3-minute washout, and 5-minute washout. So as you see in the image, the ventilation is normal in both the scans, upper one and the lower one. But the middle one, the perfusion scan, when we look into the anterior view, the left side, there is a perfusion defect, as well as in the posterior view also, the left side is showing a defect. So there is a typical finding of pulmonary thromboembolism, the large wedge-shaped peripheral perfusion defects in the areas that have normal ventilation and that are normal on plain radiograph. So this is the scheme which we are using. First we do the pre-test probability by using the well score. If the well score is low, there is no need for further imaging. If there is intermediate or high pre-test probability, we do the baseline chest X-ray, and after X-ray we do the perfusion scan, and in the perfusion scan we see the peripheries, the defects, peripheral defects, and we proceed ahead and do the ventilation scan, and we compare the areas where there are perfusion defects. If the ventilation is normal and there is only perfusion defect, we called it as a typical pulmonary embolism. Then after that, the assessment prior to lung resection is also an indication for VQ scan. So there are regional quantitation of ventilation and perfusion are obtained pre-operatively. The percentage contribution of the region to be resected is subtracted from the total lung function, and the pre-operative FEV1 multiplied by the percentage of lung remaining after resection gives the predicted post-operative FEV1 values. So these are further examples in which conditions we are using the VQ scans. The emphysema, where the ventilation is hampered but the perfusion remains normal. In the hepatopulmonary syndrome, certain other inflammatory lung diseases like ARDS, IPF, sarcoidosis, inhalation lung injury, where the clearance of the tracic particle are much higher as compared to, faster as compared to the non-inflammatory diseases. So take home message, the PET-CT is a finding increasing use in the staging of the lung cancer in post-operative, post-radiotherapy follow-up in recurrent lung cancer, and in evaluation of solitary and multiple pulmonary nodules, including the benign conditions. The false negative results can occur with well-differentiated adenocarcinoma, carcinoid tumor, and bronchoalveolar carcinomas. The overlap of benign with malignant disorders can occur, and the VQ scans have a role in females, renal failure, and contrast allergy. Use of new criteria and techniques reduces the number of indeterminate results. Thank you so much.
Sir, you are on mute. Sir, you're on mute.
Thank you, Deepak. We are really running behind the schedule. There are some very good questions, but I think I will take them at the end. But I'm really impressed, and I will answer to one question myself. I'll take this privilege of doing it. That Karthike has asked this question, which is that any specific findings on the PET scan if the patient has undergone an immune therapy for treatment of malignancy? Wonderful. Actually, the PET scan after the immunotherapy can show worsening because that is the immune cell infiltration which increases and it's called pseudo progression. And also, immune related adverse events can affect other organs of the body like colon, like lungs, or other organs in the intestines, liver, where you can actually get a false positivity, which is not actually progression of the disease but an immune reaction which is because of the immunotherapy. Wonderful question from that side, and we can move on to the next one, which is going to be the MRI, and it is the last this thing. And I'm going to say this, that MRI, because of its non-radiation potential, has really now emerging with much newer enthusiasm to use it. At one point of time, we thought that MRI will do nothing for respiratory medicine, but it is coming up like anything, and Kanishk will be covering this. Over to you, Kanishk.
Thank you, sir. And I'll be very quick with my presentation. So we'll start with the basic principles of MRI. The basis of MRI is the directional magnetic field or moment associated with charged particle in motion. So when a human body is placed in a large magnetic field, many of the free hydrogen nuclei, which is there in the body, subject's body, align themselves with the direction of the magnetic field, which is there. And then according to that deflection and direction of the magnetic field, we get an image. So that image is interpreted, and this is just an MRI principle based on the Larmor decisions. We have some contrast agents. Most commonly, contrast which we give is gadolinium based contrast, which helps us to give a better resolution or the imaging of the organs which is there subjected in the MRI. So we get three kind of images. First one is T1 based images, T1 weighted. Second is T2 weighted images, and third is the proton density weighted images. We'll see a slide, a picture of this in this slide, in which you can see in T1 weighted images, the fat cells are more appear brighter, and in T2 weighted images, the water content organ in the organ seen brighter, and in the third image you can see midway in between the as you can see in the fat and the water kind of images in T1 and T2. So what's the benefit? It's a non-invasive imaging technique that does not involve exposure to ionizing radiation. The contrast material used in MRI exams is likely to produce, very least likely to produce, allergic reaction. And MRI of chest is often more informative than other imaging procedures. MRI imaging can assess blood flow also in the angiography, MRI angiography, to give you a conventional idea about the lung lesion, maybe in the sequestration of lung itself. So indications are very simple. As an alternative to angiography to avoid repeated exposure, clarifying findings from the previous CT or chest, assess abdominal masses, assess the anatomy and function of the heart and its components in the cardiac MRI, evaluate the blood flow and dynamics, shows the structure of the chest from multiple angles, and determine tumor size, its extent and degree of spread to the different adjacent structures, and tell the difference between the tumor and the normal tissue by its consistency, as we talked in the previous slide about the water and the fat tissue. So gives us about an idea of the normal tissue and the abnormal tissues. So this is the anatomy. I think you'll have to take a picture of this and this slide, because it's very easy for you to compare that short form with the full form which is there on the right hand side. So we'll be like, for example, about the esophagus, subclavian artery, and everything is beautifully quoted there. You can take a picture of that. So its application, MRI application, we'll be talking about the tumor. So there are anterior mediastinal tumor, various types like thymohyplasia and all. Medial mediastinum tumors like malignant lymphoma, sarcoidosis also comes in between that, and cardiac MRI has a role in sarcoidosis. I think Dr. Kushbu already talked about it. And of course, in the lymph nodes, you can take a biopsy from the EBUS and get the diagnosis of tuberculosis or sarcoidosis. And in posterior mediastinum tumors, you have esophageal carcinoma and extramedullary hematopoiesis. So we'll talk about one lesion and disease in anterior mediastinum, that will be retrosternal goiter. And here I have a very beautiful image of that, in which there's a coronal MRI scan of this patient with retrosternal goiter. This patient had palpable laterally placed neck vessels, suggesting benign disease, which is the very sign. So you can typically see the thyroid lesion, which is there, in the right hand side of this lesion in the coronal MRI. In the middle mediastinal tumor, I have put a beautiful slide for you explaining the X-ray showing the lesion. Then you can see the same lesion in the CT scan. And this finding which is there on the MRI T1 and T2 weighted images, you can see the consistency is similar to like that of CSF. So that's why you have to understand what's is seen brighter in the T1 and T2 weighted images. So you can clearly see that this is a cyst, and this is the lining of the cyst can be seen in this T2 weighted images. And when we did the operate this the patient, you got the gross specimen of the bronchogenic cyst like this. So esophageal carcinoma is the next one in the posterior mediastinal tumor. These are the T1, T2 images of this esophageal. We can see moderately higher intensity in these two images, and when compared to the contrast which is given at that same point of time and with the MRI, then you can see a better, enhancement in the esophagus. So anterior medial and posterior mediastinal tumors, MRI helps in all those things. So determining the extent of the lesion is very important. In the CT, for example, you can see there is a lesion which is there, and on the contrast CT, you can see the lesion is there, but we cannot see the extent of the disease. And in the subsequent MRI, you can see that the lesion is invading the bone, but it's not invading any vessels right now. So that is very much helpful to diagnose or stage the lesion by knowing the extent of the disease in the MRI. Now coming back to the pleura, here you can see a beautiful lesion in the X-ray which is there. Now corresponding CT showed similar kind of lesion which is there, but in the MRI also you can see that the extent of the lesion and the basic enhancement which is there given after the contrast, so you can identify the extent and the disease and the lesion which is there in the mediastinum. So in pleural diseases also it is helpful, and the pleural effusion, you can see diffuse uptake on the right side more than left side. So MRI helps you in the diagnosis of pleural effusion. Also, the T1 weighted images signal intensity is more consistent with the chylothorax or hemothorax. Of course, the ultrasound will be the more useful thing in diagnosis of the pericardial fluid and the pleural fluid itself. But yes, this can also be helpful. Now, primary tumors of the chest wall, you can see the in the T1 and T2 weighted images, there is a lesion which is there extending from the chest wall, and after the biopsy, there is a inconsistent lesion which is there after the contrast which is given inside in the patient's body, and there is a lesion which can be seen in heterogeneous pattern. Now, coming back to the very well heard disease, which is the pulmonary sequestration. There are three types: intralobar, extralobar, and extralobar subdiaphragmatic. So cardiac MRI, chest MRI can give you the idea where the lesion is standing very clearly, and the pathognomic feature of this lesion is the aberrant blood vessels, which can be seen in the MRI angiography here with this arrow sign, and here we can see that it is aberrant artery which is coming out from the thoracic aorta. The tumors of the trachea, it's very clearly seen. MRI is helpful in the diagnosis of the tumors of the trachea. You can see the lesion which is there in the T1 weighted images, and here with the T1 weighted images before the contrast and after the contrast, this lesion becomes very much specific and clear. So that helps in the diagnosis of lesions in the trachea. And when it comes to parenchyma, HRCT is always better when it compares to the screening of the ILDs in sarcoidosis or scleroderma. And these are lesions which is there in adenocarcinoma lung. Both show similar kind of lesions. So HRCT is also well good, and MRI or chest is also equally good. But in parenchymal lesions, considering ILD, HRCT will be always the gold standard. Thank you so much.
Thank you very much, Kanishk. And very, very aptly, you have just finished on time, in fact, before time. And I'm sorry that we had to rush this a little bit, but you have very beautifully brought in how MRI is entering into areas which are like not fully addressed by CT scans as of date today. Dr. Richa is there.
Yes, sir. Yes, sir.
There is one question which has come, that can MR guided by, yeah. So I think there are two more questions, Richa. Can you take quickly? So in the meantime, we can go ahead with the.
Um, I'll just quickly see. Can MR guided biopsy be better modality than ultrasound guided biopsy in case of central bronchogenic masses with no endobronchial invasion? Is it ultrasound or EUS they are talking about, sir? EUS, I understand it is esophageal ultrasound. So I'm
So
not
I think,
very sure.
yeah, I think this question is not clear, Ronak, but it's anyway a very intelligent question. I think you are saying whether we should go through the EUS route or we should go through the MRI
MR
route.
guided
So
biopsy.
if we go MRI, you have to be having a peripheral one basically through the chest
Yeah.
wall. So if it's like possible to do it, then only we will be able to do it. But I think what you mean to say is that perhaps can ultrasound and MRI differentiate between the characteristics of the tumor, and can it pick that the tissue better, which is like viable tissue? So I think it's both are equal at the moment, and we have not reached the level where we will be able to answer this question. But there are a lot of other questions which I think we have not been able to take. We will give the answers to this and put it on the on the on along with the video recording of this entire episode. Thank you everyone for this. So Richa, there is I think now we have a quiz, I think. So quiz is
Okay.
still there, and then of course Deepak will present the quiz. So participate in it. And I'm not sure, Richa, can we decide on the basis of this basic questions which have come up, which is the best, or we should take time and then declare it on the next time?
Uh, I think probably next time, sir.
I think that's better. So backend team, I think it should be okay if we declare the winners of the best question ones in the next one, because we really need to look into a lot of questions, because some people have asked 5 7 questions. So cumulatively, obviously it will matter actually, if they have asked two good questions and another one has asked one single question. I think all of us will sit together and get, because this is a very important thing. But I'm very, very happy that there is a very high quality questions which have come up. Very, very high quality.
Uh, yes, sir. Sure, sir.
We can
Dr.
go ahead with
Prajapat,
quiz.
yeah, I'll share my screen, sir.
Okay, you
Okay.
are getting this. Okay, fine.
Yeah.
Go ahead.
Should we start? I hope everyone attending. We are starting with a live quiz. So, Dr. Prajapat.
Yeah, so because I am the quiz master, so whatever answers I will give you, that will be the final answer. So there may be a discrepancy between the answers, but because I am the master, so you have to follow me and you have to.
That's the rule of the quiz.
Yeah, sir. So the quiz is live now. I mean, they can see the first question.
So the first question is what is in the X-ray? So please poll for the answers, because your answer will get you exciting prize in view of Amazon voucher, which are already declared.
Can I also answer, Deepak?
No, ma'am.
And win prizes also, na Richa, we should ask for it. Can we also?
This is for only the postgraduates and the senior residents.
I think we everyone has to again. I mean, if the QR code is not yet scanned.
So you please scan the QR code and then only vote, because otherwise your vote will not count.
So show the scanner again, I suppose. You can show the scanner
Yeah.
before you start.
Yeah. Sir, we have started getting the responses.
Okay, okay.
So we get 22 responses.
Okay, that's good. Then that means, so there is no
It means
problem with
whatever.
this
So it
QR.
means whatever Dr. Richa taught them,
They
they
understood very well.
yeah, they understood very well, and they give uh,
Somebody is asking where to scan.
Yeah.
so can the backend team help? Yeah.
I'll just put up the scanner again. I mean, it's
Yeah,
visible on
just
the
yeah,
screen
yeah.
now.
Those who do not have the scanner, please, please, please scan now to answer the quiz.
This is the scanner, and the quiz is visible on your will be visible on your mobile screen.
So I think 15 more seconds.
Yes, sir.
So whosoever answered till now, they answered for the meniscus sign. So can we go onwards for the second question?
Yes, sir, sure.
So all who are attending this PG Connect program, please vote for the answer so that you have an opportunity to win Amazon vouchers.
Handsome prizes.
Also the Nova 9 packs entry also.
Okay. So the second question is live.
This is the first question, I think.
Oh, so this is the second question.
Yeah, second question. So this is the image and your options are whether this X-ray belongs to ILD, COPD, left lower lobe collapse, left lower lobe pneumonia, or I don't know. I think the first option they put is the wrong.
Deepak, down me it is coming as D is also left lower pneumonia and
Yeah.
E also is coming as
Yeah,
left
so
lower
they
pneumonia.
put the wrong option.
I don't know. E should be I don't know. Please
I
read
don't know.
it as I don't know. And please accept it. Kanishk always gives award to people who also genuinely say that I don't know.
So
Nobody.
how much time we have now?
We can, I think, move on, sir, to the next question. We have around.
Yeah.
Should we move on?
Yeah.
Yes.
So those who missed the question, we'll put it in the last. So the
Yes.
third question is,
Please go ahead with the questions at the moment. Finish because there are 16 questions. We need to finish them fast.
So the third question is live now.
so the
Yeah.
most common presentation with this CT images. So the question is most common presentation.
So he's telling you repeatedly the hint.
The most common presentation is options are mucormycosis, PJP pneumonia, vasculitis, tuberculosis, or organizing pneumonia.
So one of the thing is that all of them can cause this. Now you have to find
Yes.
out which is the most common one.
So this is little tricky. So
So
that's why
remember that I think for the postgraduates that this sign can be seen in these conditions. I think that is also a good home point to take.
yeah. So how much time we have?
Should we move on, sir?
Yes, you
Yes.
please do it actually. I think you are keeping the track of time. Please keep doing it.
Okay, sir. So now the next question is live.
So this is a little tricky one. So please read the question. 78-year-old woman, which is having a Parkinson's disease. She came with the cough and breathlessness with the room air saturation of 87% in the emergency, and X-ray showed these changes. So what is the most probable diagnosis in her case? So the options are community acquired pneumonia, lung fibrosis, pulmonary edema, aspiration pneumonia, or I don't know. I think everybody knows.
Yeah, nobody wants to score on I don't know because they are scared. I think their heads are going to scold them.
Okay, sir. So I'll move on to the next question.
Yeah.
Sapna, you say that time over, move to
Time
next.
over. Yes.
So now the fifth question. The question is least common presentation of crazy paving pattern. So read the question carefully. Least common presentation of crazy paving pattern.
So all are common, all are there, but one is least common.
So the options are diffuse alveolar hemorrhage, PAP, pulmonary edema, PJP pneumonia, or I don't know. So now I think more and more people are voting.
Yeah. So, sir, time up. I'm moving to the next one.
Yeah. So the sixth question is, what is the diagnosis in this radiograph? So your options are COPD, asthma, left hilar prominence, hiatus hernia, or it's a normal X-ray. So I think
Time's up.
next question.
Next question.
So he's a 47-year male, office job worker, never smoker. He presented to us with the breathlessness, cough for 1 year, and this is the CT finding, having a cystic lung disease, and the skin biopsy, which we are showing the fibro folliculoma. And also I think there is a one slide there which they missed is the folliculin gene.
All right. So now moving on to question number 8.
Yeah.
Which is live now.
So which ILD pattern it is? So just see the CT image. So which ILD pattern it is? Whether it's fibrotic NSIP, UIP, or it's IPF, cystic ILD, or organizing pneumonia.
Time's up for this one. Moving to question number 9. It is live now.
Ninth question is, most common presentation of this CT image is seen in which condition? I think it's still loading.
It's live. So people have started voting.
Yeah.
They are already voting. I think they can see it. We are not able to see, but they are able to see the full image because we are not able to see the full image.
Options are PJP pneumonia, bronchoalveolar carcinoma, acute hypersensitive pneumonitis, RAILD, or I don't know. The most common presentation.
So again, very important to remember when most common is being used. So remember, these are all causes of that. So take home is that please remember that every sign has got couple of causes. Remember them in your mind.
Yeah. So moving to question 10, which is live now.
The 10th question is 62-year male smoker with the history of streaky mopsis, cough, and weight loss. The sputum gene expert was negative. What is the best and safest option for the diagnosis? So this is the CT image, and it is showing the sunburst appearance. So how to approach this lesion?
So now moving on to the 11th question, which is live.
So your 11th question is 45-year female, never smoker, presented with breathlessness of MMRC grade 2. The CT scan showed a cystic lung disease. On biopsy, there are cystic areas which are infiltrated by the spindle cells, and on the histopathology, the SMA and the HMB45 stains were positive. So what is the diagnosis? So it's PLCH, LAM, BHD, UIP pattern, or I don't know.
We've got good number of responses. So now moving on to question number 12.
Yes.
Yeah,
this
which is right.
This is the X-ray. So what is most likely diagnosis on this X-ray? So it's a COPD, left lower lobe collapse, CHF, or Swyer-James syndrome, or I don't know.
Okay, sir. So moving to question number 13 now.
Yes.
Uh,
So this is
and
the
it's live.
MRI image. So in this MRI image, what you are seeing? So is it a mediastinal mass, or these are the mediastinal lymph nodes, or it's an enlarged vessel, or it's a mediastinal fat, or I don't know. So next question.
Yeah, next question. So question number 14 is now live.
So this is a 62-year male ex-smoker, came with the fever, weight loss, streaky hemoptysis, diagnosed as squamous cell carcinoma of lung. So what is the stage on the PET CT? So this is the PET CT images. So option A is 3B stage, option B is stage 4, option 3, 3A, option 4, 3C, and I don't know.
So now moving to question number 15.
So the
It's live.
question is 32-year pregnant female, 20 weeks pregnant with the history of left-sided chest pain, acute onset of breathlessness with room air saturation of 91%, raised D-dimer. How to manage this case? So your options are to do the CTPA, do the CT chest plane, or you want to do the VQ scan, or you want to do the MRI chest.
So now, sir, the last question number 16 is live.
So this is the VQ scan image. So identify the diagnosis on the VQ scan image. So what is this image showed? The normal scan, it's a low probability PE or high probability PE, or you just don't know, or it's a COPD.
So, the time's up.
Can you freeze this one, this result, question number 16? Because in this, somebody has said, I don't know.
Yeah,
So
I think
he will get this actually, all two. I think there are two
two
responses.
responses, yes.
Both of them will have a special, definitely a special reward coming up from PAX for these two people. And this is a very, very interesting. Now, are you going to calculate? And in the meantime, he tells the answers?
Yes, sir. Yes, sir. We'll need around 3-4 minutes. We are calculating.
So in
Can you stop share?
Yeah, we have. Okay, I'll unshare, sir.
Yeah.
Deepak, in 3 minutes, answer all 16. No explanations. Let them find the explanations themselves.
Yes, sir. So the first question is, what is the X-ray finding? So correct answer is meniscus sign. So
Next.
many of these, whosoever answer correctly.
Go ahead, Deepak.
Second question answer is left lower lobe collapse. The third question, the most common presentation of this CT image is organizing pneumonia, the fifth option. The fourth question, the 78-year-old woman with Parkinson's came with cough, breathlessness, saturation. The diagnosis is aspiration pneumonia. The fifth question, the least common presentation of KZ-Praving pattern is diffuse alveolar hemorrhage. So this is the explanation for this. The sixth question is the diagnosis. In this case is the hiatus hernia. The seventh question, the 47-year male, office job, never smoker, presented with breathlessness. The folliculin gene mutation was present. The correct answer is Britt-Hogg-Dube syndrome. The 8th question is which ILD pattern it is. So it is a UIP pattern. And most common presentation of this CT image is acute hypersensitive pneumonitis. The third option is the correct answer. This is the head cheese sign. The 10th question, 62-year male smoker, history, streaky hemoptysis, cough, weight loss. So what is the best and safest step is the radial EBUS. Then 11th question, the 45-year female never smoker presented with breathlessness, cystic lung disease with on histopathology, SMA and the HMB 45 stains positive. So this is a LAM. Then the most likely diagnosis on this X-ray, the correct answer is Sware-James syndrome. So this side is more hyperlucent. Then the MRI chest, it is showing the mediastinal mass. The first option is correct. Then the 14th question, 62-year male ex-smoker came with fever, weight loss. The stage is because in the PET CT there is a effusion with the lymph nodes and the mass. So the stage is 4M1. The 15th question, the pregnant female, 20 weeks pregnant with history of left side chest pain, breathlessness, raised D-dimer. The option is VQ scan, third option. Then identify the diagnosis on VQ scan. The correct answer is it's a normal scan.
Pull down the screen.
Thank you, sir.
So you have got all the answers also now, and Richa will announce the results. Richa? Richa, are you there?
I can't see, ma'am. I don't know why. Nitish, can you please unmute, ma'am? If I don't know. I mean, I
Yes,
can't
ma'am.
see. Yeah.
So is Richa there?
Yeah, she is one of the
Yes,
participants.
she's there, but she is not responding to the request. I am sending it to her about unmuting the mic.
Can somebody call her?
Yes, sir.
Call her.
So I would like to congratulate all those who participated in this quiz.
How many people have participated? We have any number back end?
Total participants are 32, sir.
Okay, 32 took all the questions. So Richa, you announced the results. First two are, first two being disqualified from because they are from MCRD.
So there is a
Deepak, you have definitely given them takeaways.
So Harshit and Ananya are from MCRD, sir?
yeah.
Yes. So they are being disqualified this time, but if they do the same next time, then I will see. But this time we have to take first, second, and third from first one will be, I do not know what is the name. I can't.
Shriti Prajna Prusti. Shriti Prajna Prusti, sir.
Okay.
And
Second,
then Vamshi Gaud Mamidi. But okay, seconds wise, she is first here. And Vamshi. And third is Sonali Swagitaka Priyadarshini.
correct. So we have got three. So we have only three winners. Is that right?
Yes, sir. Yes, sir.
Okay,
Yes.
so these three are the winners. Rest, fastest, first, and other things. The best question that Richa will see the questions and then decide.
Sure, sir.
Okay. So thank you very much, Richa. You can close the session.
Thank you everyone for being part of the Pulmoconnect and kind of a thing which we have, sir has actually seen into it, where we want to disseminate the knowledge to the postgraduates or to the people who are early career pulmonologists. And we have tried our best to put these 8 modules in the best of the way, the common things which are not so common. And sometimes things can be very uncommon, and that's the reason why we have put it up these well curated modules, 8 modules as a Pulmoconnect. So I hope this was our first session. We also learned, and we were little late, not little, we were an hour late. But we are sure that from next time onwards, we are going to stick to the time as much as possible. And we want to we are happy that you have participated with such an enthusiasm. And we look forward to have more enthusiasm, more participation, more interaction, because this is what we want, a learning process for you as well as for us. So with that, and I think we would like to conclude this session. And we look forward for the second module, which would be announced very soon, the dates and the details.
Yes, watch for the second episode now. Thank you very much, everyone.
Thank you so much, everyone. Good night.
Thank you, sir. Thank you, ma'am.
Bye-bye.
Bye.